I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of June 18th, 2025 to order. Melissa, if you could please, at approximately 9:03 a.m. Pacific. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns is excused. Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy is excused. Robert Judge.
Present.
Chris Lehman.
Present.
John Murray will be joining a little bit later. We have a quorum, Chair Bailey.
Melissa, thank you. For everyone here today, we do also want to welcome the American Sign Language interpreters with us. Please use the Zoom channel controls to access the interpreter channel. So welcome to our interpreters. Melissa, thank you for providing that slide. And welcome to our interpreters who are supporting us today throughout the meeting. Melissa, can we just at least confirm that the interpreters, excuse me, I guess we've shared the information here. So we'll go ahead and leave this on the screen for a moment while I move forward with the next part of our agenda, just so the public has time to access our interpreters. So today our agenda begins with a conflict of interest declaration, which are stated each month according to board policies. Do members today have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? And/or have board members provided testimony to the Oregon legislature about prescription drugs? If so, please go ahead and raise your hand now and give the committee name and date. So do any of my colleagues here today have any actual or perceived conflicts of interest they want to reference? Melissa, I cannot see all my peers' images here on the screen today, but I don't see any hands raised, so I am going to move forward with the next portion of the agenda. So related to that piece of the agenda, I would like to ask my colleagues here if there are any changes to the draft minutes from the May 21st, 2025 meeting. And if there are not any proposed changes to the draft minutes, I would like to ask for a motion and a second to approve the minutes. Do we have a motion to approve the minutes?
I will motion Chair Bailey to approve the minutes. This is Chris.
Thank you, Mr. Lehman. Do we have a second to approve the May minutes? Ms. Hoagland, I see your hand is raised. So are you raising your hand to provide us with a second?
Yes.
Okay, thank you. Melissa, if you could please call roll. And I do believe, Melissa, you may have an update you want to provide related to the minutes before you call the roll.
Yes, thank you, Chair Bailey. The minutes have been updated to include all the names of the speakers during the May 21st meeting. So now I will go ahead and call the roll.
Thank you, Melissa.
Dan, yes, you're welcome. Dan Hartung.
Aye.
Lori Hoagland.
Aye.
Robert Judge.
Abstain, I was not present.
Chris Lehman.
Aye.
Chair Shelley Bailey.
Aye.
Okay, I believe that we need one more vote to have those minutes be approved.
Okay.
So we might have to come back to those.
Yeah, and Melissa, what I would do is I would like to suggest that if someone can help remind me, I'll also write a note that we could work hard to approve the minutes at the end of our meeting. Mr. Murray there's a citywide connectivity issue related to the internet in the area of Oregon in which he resides and supports the community. So it is our goal that he will participate in some part of this meeting, although we cannot be certain of that at this point. So we will go ahead and address the minutes at the end of the meeting. Melissa, thank you for your support related to that. So I would now like to call on Program Executive Director Ralph Magrish to provide us with a program update. Ralph, welcome, and you have the floor.
Thank you, and good morning. And just a few brief updates for folks. No, we got a lot of folks signed up for public comment this morning, so we'll move through fairly quickly. Pleased to share that the governor did sign Senate Bill 289 on May 27th, which was our PDAB bill. As a reminder to everyone, that bill did three things, and it will become effective in January of next year. That will change PDAB's charge to identify 9 drugs a year that may cause affordability challenges to language stating up to 9 drugs a year. It also removed the requirement for DCBS rather to provide the PDAB with a list of drugs each calendar quarter that was subject to 60-day price increase reporting. And finally, it replaced the generic drug report annual requirement with a new provision that relevant content would be incorporated in the affordability review reports themselves. Speaking broadly to DCBS updates, DCBS will be hosting a public hearing on rulemaking related to the licensing of pharmacy benefit managers. That was pursuant to House Bill 4149 of 2024. That public hearing will be next Monday morning, June 23rd from 11 to noon. Information about that is available on the DCBS rulemaking page. And finally, on that front, public comments on that rulemaking can be submitted to the agency directly at dfr.rules@dcbs.oregon.gov. Again, dfr.rules, R-U-L-E-S, at dcbs.oregon.gov. Those can be received till 5 p.m. on Monday, June 30th. Next up on PDAB business, our recruitment for the vacancy created by Robert Judge's departure will remain open until July 7th. Some folks may note the previous deadline was June 6th. We received word from the governor's office that because September legislative days, which historically have been held earlier in the month of September, have now been scheduled for September 29th to October 1st, they were able to grant boards and commissions an extra month of time to keep recruitments open. So to that end, we welcome any interested Oregonians who meet the requirements of having expertise in clinical medicine or healthcare economics to apply, and information is available on our website. Finally, I want to take a moment. I want to thank Robert Judge for his contributions to our board since its inception in 2022. Robert, on behalf of the entire staff, I want to thank you for your willingness to share your insights, your knowledge, and your perspectives with all of us, and we thank you for your service. So truly appreciated, truly appreciated, and we thank you and we wish you the best of everything going forward. At this time, I'd like to welcome Jesse O'Brien, our policy manager from the Division of Financial Regulation, and Jesse, right on cue, is being admitted into the room. How perfect is that? Jesse's been running around pretty frenetically the last number of weeks, as you can imagine, as our policy manager. Melissa, if you can give a green light that Jesse has been promoted to speaker, we will hand off right to him in stride. Thank you.
Jesse, I did just update your settings. There you
Right. Good morning, everyone. Can you hear me?
Yes, we can.
go.
Great. Okay, well, good morning, Chair and members of the board. I'm Jesse O'Brien. I'm the policy manager with the Division of Financial Regulation, here for what will be the last legislative update of this session for the board, because the session is ending in just less than a couple of weeks at this point. It is constitutionally required to end no later than June 29th. Could end earlier than that, but nobody really ever knows exactly when it's going to end. So I shared the update on the bills that we've been tracking for the board with Melissa, and that got shared out with the group and it is up on the screen here. There's only a few updates relative to the updates I provided last time around. There's a couple of bills related to related to 340B and PSAOs, Pharmacy Services Administrative Organizations, that have passed and been signed by the governor since we last talked. But there's a number of bills that are still kind of sitting out there awaiting action. Some of them are sitting in the rules committees, which are not subject to the deadlines, so they could still move forward. Others are in this kind of unusual situation of having passed a committee, but not having been scheduled for a floor vote, which historically is pretty unusual, but there's been a surprisingly large number of bills where that's happened this session, and technically those bills could still move forward. There was an unrelated bill that we've been tracking that's been in that position for like a month or more that actually just got scheduled for a floor vote recently. So it's still possible technically, but they are definitely running out of time. So I would strongly suspect that the bills that have not seen action since being referred to rules or since passing out of committee are most likely not going to pass at this point, but I don't have any special inside intel about that. But I think from our perspective, the most significant bills that are still sitting out there are the ones related to licensing PSAOs. That's House Bill 2149, and tightening up requirements for pharmacy benefit managers, PBMs. That's House Bill 3212. They still could pass, but have not seen action in quite a while. And Melissa, if we could just go down to the second page of this. So the other bill that has passed and been signed was the set of technical fixes that the board had recommended in Senate Bill 289. So that has been signed into law and has made it all the way through the process. But yeah, that's all the updates I have as far as prescription drug related bills at this point. There's a lot of other things going on with the legislature, but don't need to get into that now. Anyone have any questions?
Hey, Jesse, related to the PSAO bill, since you referenced that it passed, I haven't been following this one as closely as I should be, but does that mean for the intents and purposes of this bill that PSAOs are identified as pharmacies and not as PBMs? Is that the next piece of the inference?
Could we go back up to the previous page? Sorry. Yeah, so there were two bills related to PSAOs that we were tracking. One of them, House Bill 2149, which has not passed, would require them to be licensed by us, by DCBS, as a new type of licensed entity that would be subject to various types of restrictions on their conduct and so forth. The bill that did pass was House Bill 3226, which is not a new licensure program with us. It includes PSAOs within the definition of pharmacies for the purpose of making sure that PBM contracts with PSAOs are subject to the laws governing the contract between a PBM and a pharmacy. I think the idea is that there could be some question if the PSAO was acting as an intermediary, whether the PBM laws applied. So that's basically what that bill does.
Okay, thank you. Dr. Hartung, your hand is raised.
On the law that passed that does the technical amendments to our authority, is that going to effect immediately, or is that when is that going to effect?
I believe it does, but let me double check that real quick. I guess it goes into effect January 1st, actually, because it does not specify an effective date in the bill. I had misremembered.
That was my recollection. Thank you, Jesse, for clarifying. And then related to, since I don't see any other hands from colleagues at the moment, related to House Bill 3212, can you tell us more about it being referred to the House for rules?
Yeah, so it got referred to the House Committee on Rules, which is one of the both chambers have a committee on rules, and it's one of the committees that is not subject to the legislative deadlines. The kind of core business of the rules committees has to do with elections and political processes and campaign finance and that sort of thing. But they also sometimes will get bills referred that just need more work, or that are kind of high priority and contentious that legislators want to keep alive, to keep working on and see if they can find a solution. So that's my understanding of what's happening with that bill, is that the legislators referred it there to keep it alive so they could continue working on it to see if there was a path forward for it. So that there's still procedurally time for the bill to pass potentially, but they are rapidly running out of time. So you'd need to see action on it pretty soon for it to pass.
Okay, thank you for clarifying that. I appreciate it.
Of course.
Do any of my colleagues have any additional questions for Jesse? And as an update to my peers, I believe Board Member Murray is still attempting to attend via Starlink. So we will continue to await his presence in the meeting. So Jesse, thank you for providing the update to us today.
Yeah, thank you all.
Thank you. We are now moving to the public comment period of our agenda. The board received 14 written comments, which we have reviewed and posted to the board website. I will go ahead and read those who provided written comment right now before I outline those who provided a request for oral testimony. Again, all of these letters are posted on our board website and have been individually sent to board members as well. So those who provided written comment related to today's board meeting are James Lee from the Community Oncology Alliance, Josie Cooper from the Alliance for Patient Access, Carol Elkins, who's a retired individual, Lauren Sant from Caring Ambassadors Program, Tom Brownlee from Pfizer, Tiffany Westrich Robertson from Each Coalition, Bill Head from Pharmaceutical Care Management Association, PCMA, Marianne Cooper, representing Cigna, Kaiser Permanente, Moda, Pacific Source, and Regents, John Mullen from the Oregon Coalition for Affordable Prescriptions, Scott Bertani from Health HIV, Michael Valenta from Johnson & Johnson, Brian Mayo from the Oregon State Pharmacist Association, Rainier Simmons from the Community Access National Network, as well as Seth Grenier from the National Multiple Sclerosis Society. The board also received 8 requests to speak. I will call on those who signed up to speak and ask them to please state their name and organization. Each will have 3 minutes to speak, and as a reminder, the board will not deliberate on issues or requests during that time. So the first individual that appears on my list today is Gabby Gardner from Basic Rights Oregon. Gabby, if you can please confirm that you're here.
Yes, I'm here.
Okay, welcome, Gabby. It looks like you are already set up to present, so welcome and you have the floor.
All right, awesome. Thank you so much for the opportunity to speak to you all today. My name is Gabby, and I'm the lead statewide engagement manager for Basic Rights Oregon. And BRO is also a member of the Equality Federation. We're a nonprofit organization dedicated to ensuring that all LGBTQ+ Oregonians experience equality. I'm here today because I'm concerned that including antiviral drugs that treat HIV in the PDAP's affordability review process will only harm patient access to life-saving medications. HIV is a unique disease that requires individualized treatment plans developed in careful consultation with trusted healthcare providers. Often, patients take 2 or more medications at once to treat HIV, resulting in complex treatment regimens. The Oregon PDAP's consideration of a therapeutic alternative when evaluating the cost of a drug fails to consider the nuances of complex diseases such as HIV. There is no one-size-fits-all approach, and patients should be able to access the right drug for them at the right time. If patients are forced to switch treatment plans for non-medical reasons, they may experience serious side effects, access to affordability challenges, or be burdened with increased travel time or lack of transportation options to seek out different providers or pharmacies for their treatment. This stands to negatively impact treatment adherence and worsens the health outcomes for patients living with HIV. I also want to highlight that LGBTQ plus Oregonians report living with health conditions or chronic diseases at higher rates. In Oregon, over 7,500 people are estimated to be living with HIV. It's important to remember that by weakening the immune system, HIV makes it easier for patients to get sick with other conditions. To be clear, interfering with carefully crafted treatment regimens may lead to virus replication, exposing HIV patients to additional long-term health issues. At the same time, the board cost review process does not recognize the existing public and private patient assistance programs that support people seeking treatment for HIV, such as state AIDS, drug assistance programs. Currently, these programs provide medications to low-income people living with HIV, supporting both access and adherence to the treatment. The Oregon PDAB has been presented with information on how these existing programs ensure affordability and access to HIV medications and acknowledge the concerns around the potential impact PDAB may have on the HIV community and care environment. Despite this, the Oregon PDAB may disrupt these programs and patient protections, ultimately creating barriers to accessing medications made affordable to patients through existing programs. As the federal government cuts for HIV research and prevention, it is even more critical that the board does not harm the HIV care ecosystem. I urge the board to consider the unique needs of patients living with HIV and the many experiences of people dealing with the challenges of chronic conditions. HIV drugs should be excluded from the PDAB cost review process to preserve access to life-saving medications for patients, providers, and their loved ones. Thank you.
Thank you, Gabby. Next on our list, we have Melissa Horn from Arthritis Foundation. Melissa, if you could please confirm your attendance here.
And Chair Bailey, I have searched and haven't found Melissa Horn, and I wonder if Melissa Horn is in the meeting, if it could please raise their hand in the Zoom setting.
Thank you for that, Melissa. We'll go ahead and still follow that process, but I will move to the next presenter and I'll circle back, Melissa, if you identify the individual as here at the end.
Okay.
The next individual that I have on my list here today is Lauren Sant from the Caring Ambassadors Program. Lauren, if you're here today, welcome and you have the floor.
Good morning, and thank you very much for having me speak today. My name is Lauren Sant. I'm the Executive Director of the Caring Ambassadors Program. Chair Bailey and board members, the high cost of prescription drugs is a significant concern for everyone, and controlling these costs should be a priority. I appreciate that you have a challenging task ahead of you. However, after 2 years of participating in almost every meeting, I remain unclear about your definition of affordability. What consistent metric will you use when reviewing the extensive list of medications in the 5 meetings indicated in your calendar? Affordable to whom? When I provided my written testimony online last week, I did not have the survey information that was subsequently made available by staff in the meeting materials. Unfortunately, the majority of the feedback that you received was from Medicare patients. Given that Medicare is out of your scope of work, these surveys should be deleted or at least analyzed separately. When removing the Medicare data from slide 18 in the packet, the majority of drugs under review have fewer than 3 responses for each, and 3 have no responses. 2 out of the 3 metastatic breast cancer drugs had no responses listed, nor was Taltz or Defici. So I would not describe this data as robust. As a 26-year advocate for people living with cancer, it is grave concern to me that the 3 oncology drugs that all target metastatic breast cancer are on the list for consideration. Cancer therapy is individualized and should involve shared decision-making between patient and provider. Additionally, these drugs administered in a medical setting are combined with other medications. So how does a patient tease out all of those variables to answer your survey? Any potential access issue, even if inadvertently caused by this review, could result in significant harm or loss of life. And again, I ask you, affordable to whom? I lost my best friend at the age of 40 metastatic breast cancer. She would have done anything to be alive with me today. I'm concerned that the drugs chosen for review disproportionately and target the chronic disease population, the very ones that need innovation to cure their conditions. And yes, innovation comes at a cost, but if a new therapy enables your liver or your immune system to function more effectively, allowing you to work and lead a healthier life, what are the cost savings to the system and to you? Unfortunately, that you as PDAB board members do not have the authority or the tools to review the entire healthcare system for opportunities to decrease prescription drugs costs. If you're only given a hammer, then that's what you use. However, I implore you to consider all the concerns of all the stakeholders and collaborate with everyone to develop a more effective process. Asking patients and manufacturers to provide personal or proprietary information through non-secure means is not an effective way to garner critical data points you need to make effective decisions.
Thank you, Lauren. Thank you, Lauren. We're at 3 minutes. I appreciate the time today. I also see Courtney's hand raised. So, Courtney, I do want to reference, have we confirmed that Mr. Murray is here today?
Yes, John is on, and I was just raising my hand because we don't have the timer up, and I just wanted to acknowledge the time was over.
I appreciate the confirmation on both. The next individual that we have on our list here today is Tiffany Westrich Robertson from Each Coalition. Tiffany, if you're here today, welcome, and you have the floor.
Thank you so very much. Again, my name is Tiffany Westrich Robertson. I'm representing Ensuring Access Through Collaborative Health, or EACH, and actually we have a second coordinating coalition called the Patient Inclusion Council, which is a novel patient and caregiver coalition, also a person living with axial spondyloarthritis and on one of the drugs under review. I would like to first thank you again for this opportunity and, like Lauren, acknowledge the daunting task that is set before you. And I do hope that you will lean more and more on all of the groups who religiously come here to weigh in, but also to remind you that we are here as a resource. In saying that, today I want to focus largely on the patient-facing drug survey analysis. Some of you may know my background is not in advocacy. My background is in education and in research, so this is really in my wheelhouse. I think to Lauren's point, the most obvious issue that I want to bring out is that Medicare is included, which cannot be covered by the PDAB, but more so, and I'm sorry, I've got the analysis, I'm on the other slide. More so what I see is in some of the slides that you're going to be reviewing, it's blended into the analysis, and that tends to skew the information that we're looking at. I did want to also second what Lauren said, that if we left out the Medicare, we're looking at maybe 50% or less of the people on here. I did want to point out an example of why this is an issue. So I grabbed Eliquis, which I'm looking here, looks like the most respondents. But of those, 76 were on Medicare. So 23 of the people were not on Medicare. Interestingly enough, also, if you look at the other slide, 23 people on Eliquis reported paying $0 to $49 out of pocket. And so that to me says maybe Eliquis is affordable to the people who are on that you could cover, and the issue could be in Medicare. And so I encourage you, when you're doing your report, to stratify that information and provide information in your report that Medicare might need to be looked at to help the Oregonians. I also just wanted to point out that the slide covered and not covered by insurance, that question is actually kind of impossible to answer because, for example, patients will often say step therapy means it's not covered. So there needs to be more granular analysis when it comes to that. Also, those on a patient assistance program, that verbiage is usually saved for either Medicare or for people who are uninsured. So it could be a language barrier. They're usually called copay assistance programs when it's on commercial insurance. Lastly, these are just examples of what we at the Patient Inclusion Council, who include people like me who are patient research partners, could do to help you in ensuring that your analysis and patient-facing materials are robust. Please consider us as you move forward as a resource to help make sure that patients patients are covered with who need to be covered and addressed with affordability, and that we are really addressing what Lauren said, the affordability for whom. Thank you so much for this time. I appreciate it.
Thank you for being here today. The next individual that we have signed up to provide testimony is Marianne Cooper from Regents Blue Shield Blue Cross of Oregon. If Marianne is here today, welcome and you have the floor.
Thank you so much. Marianne Cooper here today, just with Regents Blue Cross Blue Shield of Oregon. I think we got signed up on behalf of the coalition that we submitted a letter with, but this is just my testimony. I am the Director of Government Affairs at Regents Blue Cross Blue Shield of Oregon. Thank you for the opportunity to comment today. In the prior two meetings, the board discussed replacing Robert Judge's upcoming vacancy with another clinical perspective. Judge's departure represents the loss of the board's only insurer representative with experience in the complexities of financing prescription drugs, weighed against drug safety, and their proven or unproven benefits. Health plans occupy a unique position in the prescription drug ecosystem with comprehensive visibility into both medication utilization and healthcare patterns across entire member populations. With prescription drugs now consuming roughly 30% of healthcare spending, payers' data-driven insights are irreplaceable, revealing which high-cost medications truly reduce total healthcare expenditures, which simply increase premiums without providing benefits. Without payer representation, the board loses access to critical real-world evidence that connects drug pricing decisions to their actual impact on healthcare costs. Insurers represent a spectrum of perspectives ranging from government agencies to small and large businesses, all of which shoulder the overwhelming burden of drug expenditures. With already alarming drug costs and a pipeline of new medications projected to exceed current prices, removing insurance expertise from a board specifically chartered with prescription drug affordability eliminates valuable insight into managing drug costs, creating unnecessary blind spot in the board's decision-making process. Proposals crafted without health plan expertise will inevitably lack comprehension of drug spending drivers, the disproportionate impact on small businesses, the subsequent challenges employers face in maintaining affordable coverage, the ripple effects on insurance premiums, and ultimately the financial burden shouldered by Oregonians at pharmacy counters. This compromises the board's core mission and the credibility of its recommendations. Additionally, health plans provide practical insight by identifying potential barriers and misaligned market incentives before policies are finalized. This forward-looking ability ensures that well-intentioned affordability measures don't inadvertently create new barriers of access for vulnerable patients or introduce new loopholes that other stakeholders might exploit to increase prices elsewhere. Their expertise is invaluable for ensuring that reforms achieve their intended outcomes without triggering a cascade of unintended consequences. The position health plans hold in the market requires them to be pragmatic due to their direct responsibility for providing accessible, high quality, and affordable health care. Insurers navigate the complex intersection of regulatory requirements, market dynamics, and economic realities that are paramount when crafting viable solutions. True progress in prescription drug affordability requires insight from those who must ultimately translate policy concepts into coverage decisions, directly affecting patient lives and healthcare costs. Insurer expertise on the PDAB isn't just beneficial, it's fundamental to developing prescription drug policies that deliver meaningful affordability improvements for Oregonians. I appreciate your time and consideration.
Thank you for being here today.
Thank you.
The next individual that we have who signed up to provide oral testimony is Katie Chandra from Genentech. Katie Chandra, if you are in attendance today, welcome, and you have the floor for 3 minutes.
Thank you, Chair Bailey and members of the board. I'm Katie Chandra, Head of State Policy for Genentech. As I begin, I want to draw your attention to Genentech's written comments shared with the board, specifically those submitted in the last 6 months, which address the board's drug selection and affordability review processes. We know the board is eager to proceed with your work. However, we believe it is essential to focus first on an aligned definition of affordability. This foundational discussion was a missing component of the board's 2024 process, and the acknowledgement of this gap was a pivotal moment in the decision to pause affordability reviews last year. As part of your discussions today, the board must align on the prioritized criteria that underpin your affordability goals and critically evaluate whether you have the appropriate data to proceed in the drug selection process. Any approach that does not consider all of the data necessary to meet the board's affordability goals would be incomplete and lead to inappropriate drug selection. We appreciate the effort by the board to update the drug dashboard with additional data. However, even more data was released this week after publication of the meeting materials, with insufficient time for meaningful review. We have concerns with the accuracy of the dashboard, including discrepancies between information from the data call and the APAC. The board must clearly identify the methodologies used to calculate estimates and averages, investigate outliers and discrepancies, and further validate the contents of the dashboard before utilizing this information. We ask the board to delay any decisions until all data can be reviewed and validated. In my remaining time, I want to remark on both Ocrevus and Perjeta, two Genentech medicines that appear on the current subset list. We ask you to thoroughly review our RFI responses and our letter submitted last month before making any final affordability review decisions. Regarding Ocrevus, we urge the board to review the materials from your June 2024 meeting, which demonstrate why Ocrevus should not be selected for review. First, Ocrevus is priced lower than other disease-modifying therapies treating multiple sclerosis and is the only FDA-approved treatment for primary progressive MS. Second, Ocrevus delivers high value to payers, the healthcare system, and society. And new modeling shows improved access would lead to a potential savings of over $14 million to the state over a 10-year period. Regarding Perjeta, Genentech believes it is unsuitable for review. First, there is very limited utilization data, and it is the only drug in the dashboard with no data from the APAC. Second, Perjeta is approved for use only in combination with other medicines to treat HER2-positive breast cancer with differing multi-drug treatment regimens for metastatic and non-metastatic disease. Reviewing Perjeta in isolation with limited data would be incomplete and not in the best interest of Oregon patients. For these reasons, we request the board remove Ocrevus and Perjeta from the 2025 subset list. Thank you.
Thank you for your comments today. I do want to acknowledge the next individual that we have signed up to provide testimony is Jessica McBride from the Oregon Coalition for Affordable Prescriptions. Jessica, if you're here, welcome, and you have the floor.
Hello, my name is Jessica McBride, and I work with the Oregon Coalition for Affordable Prescriptions, or OCAP, and thank you for the opportunity to comment today. OCAP represents the families, seniors, and countless other patients across the state who struggle to afford the medications they need. We do not take money from the pharmaceutical industry. OCAP strongly urges the board to stay focused on protecting Oregonians from high prescription drug costs by doing everything possible to avoid further delays in the affordability review process. High prescription drug costs are an urgent problem, with more than 1 in 4 adults in Oregon reporting skipping or rationing prescriptions in the last year due to cost in a recent Adjournment survey. We also want to recognize the fear and anxiety that any suggestion of reduced access can cause, particularly for patients with few or no alternatives, and that those concerns are very valid. At the same time, it's important to recognize that the orphan drug designation, while well-intentioned, has been increasingly used by manufacturers to secure generous federal benefits for drugs, including those that are already on the market and are used to treat common diseases. Today, 6 of the top 10 selling drugs had the orphan designation. And more than half of orphan drug spending is for non-orphan uses. These market distortions must also be part of a balanced conversation on affordability. PDAB's determination that a drug may create affordability challenges for healthcare systems or high out-of-pocket costs for Oregonians simply allows the state legislature to consider whether further action is needed to improve affordability. The pharmaceuticals industry suggestion that companies would leave Oregon as a result is a familiar scare tactic. In practice, manufacturers continue to operate in countries with much stronger pricing oversight because some profit, even if reduced, is better than none. We appreciate your thoughtful approach to the upcoming affordability reviews and understand that adjustments to the drug list may be necessary. However, we urge you not to categorically exclude all orphan designated drugs from review. Doing so would leave a growing and increasingly expensive category of drugs outside the transparency and accountability that Oregonians expect from you. Please continue to center the voices of Oregon's families, patients, and caregivers who are most affected by high drug prices, including those living with rare diseases. Act with urgency, resist industry-driven fear tactics, and fulfill the mission of PDAB to protect Oregonians and the state's healthcare system from the high cost of prescription drugs. Thank you.
Thank you for being here today. The next individual who signed up to provide testimony, who's on my list here today, is Daria McGrew from Pharma. Daria, if you are here, welcome, and you have the floor and 3 minutes.
Good morning, Chair Bailey, members of the board, thank you, Daria McGrew, on behalf of Pharma. I really want to thank the board and the staff for all the work that went into the 2 dashboards now in an attempt to increase transparency. That's an incredible amount of work and an incredible amount of data, but there has been quite a lot of confusion and concerns with all the data that we're looking at from manufacturers and other stakeholders. So I want to focus my comments today just on transparency and methodology concerns about the dashboards. First, I ask the board to create far more comprehensive data dictionary and methodology documents for both of them. For example, just a few points, several elements say average, say that they're an average of something, but it is not clear what was averaged to get to that, what numbers or what elements were averaged, including a description. We would like to see a description of which data elements are carrier reported and which data elements are calculated by the board and how they were calculated, the specific formula. It is not exactly apparent what you mean when you're averaging or not. Also, when are elements net of rebate or gross of rebate? These are just a couple of things that every single category of data needs to be defined. A couple other points. The first dashboard that was used for the initial review was created from carrier reported data based on the drug lists that they provided. The new dashboard also contains carrier reported data from the data call, but these 2 data sets do not match each other. When you look at what the carriers reported the first time, it's very different from what the carriers reported the second time. So no explanation of the differences. If they are at the same time frame, why are they 2, 3, 4 times more if just looking at enrollees, for example? Also, I'd really like the board, we request that you clearly define and differentiate the universe of covered lives represented in carrier reported data versus the APAC. According to the DPT 2024 annual report, 11 reporting carriers represent a quarter of Oregon covered lives. According to the APAC, that data set is estimated to represent 90% of the covered lives in Oregon. However, when you look at the data sets, there's a huge amount of variability. Some drugs, if you look at number of enrollees, the APAC data is 10, 20, or even 40-fold more patients on some drugs versus what the carriers reported. So it really raises questions about what is going on and why there's such differences. I could go into more, but I encourage the board to talk to stakeholders who are the primary users of this to seek feedback on what is different. And at this point, the dashboards are not ready to be used for affordability reviews. So I ask you to please expand on those before moving forward with reviews. Thank you.
I've had my audio off. I apologize. Thank you for being here. The next individual who signed up to provide testimony we're circling back with is Melissa Horn from Arthritis Foundation. Melissa Stiles, if you could confirm whether or not Melissa Horn is in attendance today.
Chair Bailey, she reached out and is having trouble with technical difficulties, so she will not be speaking today.
Okay, Melissa, thank you. Thank you for sharing that with me. And before we move on to the next portion of the agenda, while the board doesn't deliberate or respond to public feedback, I do just want to provide clarity for everyone here today to reinforce that related to the open position we have. We encourage everyone who meets the definition of eligible per our someone with background in medicine or healthcare economics to apply. So the board will advance applications from anyone who is qualified to apply. So just wanted to clarify that for the record. We now are moving to the board review and possible vote for an updated data subset list of prescription drugs and insulin products pursuant to OAR 925-200-001. PDAB is directed by ORS 646A.694 to conduct drug reviews on prescription drugs and insulin products. At the March 19th meeting, the board voted on a subset of 27 prescription drugs for review. At the April 16th meeting, the board voted on a subset list of insulin. Today, the board will review and possibly vote on updated subset lists of prescription drugs and insulin products. I will call on Courtney Whitlock, Senior Policy Analyst, to get us started related to this conversation.
Great, thank you, Chair Bailey, and thank you, Board. I wanted to start off with kind of going over the feedback from the patient surveys, focusing. I know we had multiple requests for informations from individuals with medical backgrounds and 340B clinics, but really wanted to provide just an overview of the patient survey information. And this information will be provided in more detail in each of the material packets that will be provided for each drug that will be selected under review. I'm going to share my screen and run through some data points. Give me just a second to set it up. Apologies. All right. So starting off, we did collect 263 surveys. 5 of them did need to be removed due to the unusable information that really didn't pertain to any drug. Most of those comments were provided just regarding concerns of drugs being unaffordable overall. What you see here is the overall input from the drugs or from the surveys. You'll see that there's a handful that are blue. These survey results provided no range values. The intention was for this survey was to collect kind of the impact, preferably the patient out-of-pocket cost impact on patients. And during the time of the survey, we kind of left it open-ended for people to provide their dollar amounts. The dollar amounts became too much to kind of try to find an aggregation. So we structure them into out-of-pocket ranges. And anyone that had no range posted is identified in this overall chart. We removed those, the unreported ranges, and came up with this graph indicating the kind of overall impact of various drugs from the out-of-pocket range from the patient's perspective. Yes, Eliquis does have the highest impact, showing majority had only paid $0 to $49 for out-of-pocket costs, and this is associated with either insurance coverage, depending on the insurance coverage. Those with the higher cost usually was associated with a lack of insurance or the type of insurance that they were provided. And I do apologize, I have a really hard time seeing any hands up. So Melissa or Steve or Chair Bailey, if you see any hands up, please let me know so I can address anybody's questions. But staff, if you have, or board members, if you have.
Verbally, I'll chime in, but you said that, and magically we have hands.
Okay, I see Robert's hand up.
I saw Mr. Judge's hand first, so Mr. Judge, you have the floor.
Well, thank you, Chair Bailey, and I really want to commend staff for this work. It's really, these will always improve, but I think as a foundational set of information, it's helpful. But I do have a couple questions on this relative to the slide before. I appreciate you taking out the unreported information. When I was thinking about this and the timing of the survey, is there a potential that the patient out-of-pocket costs that we're recording could be impacted by seasonality of their coverages? I'm thinking early in the year, you have an out-of-pocket obligation you have to satisfy in terms of a deductible before your insurance kicks in. Were there any questions relative to that in the survey itself? Because I'm trying to get to true impact to members.
Yeah, so actually the question that was asked in the survey was, what was your last monthly out-of-pocket cost? And so we didn't ask annually. We asked what the prior out-of-pocket cost was. And if for some reason that they indicated any sort of annual or they weren't sure, then we broke it down to a month cost.
Okay, so would it be an incorrect or correct conclusion to say, based upon the timing of the survey, that the where an individual is in satisfying their deductible was not considered or could not be considered and reported on in this report. And the reason I'm asking that question is because the consumer side is hugely important, but as we also know, there's a payer side to this thing that is equally important, maybe of more significant importance in terms of total dollar out of pocket spend.
Yeah, and then for this survey information, we didn't collect down
Yeah.
to that.
Yeah.
We just, again, tried to get to at least what the previous month was. And so that would have been, so yeah, it could have been an impact from deductibles just because we collected it in March and the end of April through April. So some could have still had a deductible impact, but it wasn't never clarified in any of the survey information, which is again, things that we've learned through this survey process of the importance of being a lot more detailed for collection. But overall, this represents is what the previous out-of-pocket would have been for the patient.
Okay, and if I could just ask one more question, Dr. Hartong, if that's okay, step in front of me. I just have one more question.
Go for it.
And this is probably more of a future guidance. I really like the cost banding that you're depicting here. If there's a way to kind of correlate that to the types of insurance coverages, that would be informative and helpful.
Okay, I think I might have a couple slides. If not, then that could be something I can add into the individual packets when we get those developed.
Okay, thank you.
Yeah, and Dr. Hartung?
Yeah, so just to piggyback on Robert's comments about the deductible phases, and yeah, so these are mostly Medicare and commercial insurance, and they may have, the out-of-pocket costs may reflect just the high cost of the drugs initially and until they get into their coverage periods. I mean, that doesn't, I still think that reflects the price of these medications, and which I think is important to note. The other thing I just want to note is that if you look at just the highest response, drugs with the highest response, just if you're trying to like make meaning out of this, anything like the mustard color is $100 to $200, $199 per month, and everything up higher than that is more expensive. So it almost appears to like at least half of most of these drugs, patients are reporting out-of-pocket costs at least $100 per month, so about $1,200 a year. Just to kind of put it this a little bit, a little context for what people are facing, with data limitations discussed in terms of this is Medicare and commercial insurance predominantly.
Correct.
That's it.
Okay. I see Robert hand back up or.
Yeah, sorry, just Dan's point made me think of something. So this is payer reported data, insurer reported data. And so what we don't have in this, and I don't know.
This is actually patients who provided feedback. This is nothing to do with payers.
Okay, got it. So what we don't know is, well, I just answered my question. This is what they've spent as opposed to any copay contribution that we get from a manufacturer.
Again, we didn't collect to that. The patients were not aware of what like a manufacturer coupon would have been or anything like that. So because we did ask for that and it wasn't provided. Most of them, in fact, I apologize, I'm going to skip to this. So the unknown here, the 4 were because patients were on patient assistance programs and they did not know what the coupons or discounts were under their programs. So again, this is a strictly patient out-of-pocket cost that the patients reported.
So all qualitative survey data, Mr.
Yeah.
We have more comprehensive info in the dashboard, but this was all qualitative from the surveys.
Yeah. Mhm.
Dr. Hartong, I see your hand back up.
Oh, I just wanted to ask, and you mentioned that, I think this is helpful to get this broad overview, but there's significant data limitations with this response bias, stuff like that.
Yeah.
In what format, and you mentioned this is going to be embedded in the affordability reviews when we get to that. In like what format is this going to be presented to us? I almost think just because of the qualitative nature of the data we collected, it's less amenable to like this type of data. I mean, this is nice in terms of like how many responses we get. Obviously Eloquist is a very people are concerned about it. And so, but I think even just if there's any way just to like dump the raw data into a form or whatever, where we can like just skim the responses from patients might be more helpful in the affordability review.
Mm-hmm.
So just a thought.
Yeah, I can think about that in the sense of I also have to be mindful of some of the PIP that was provided. That's why I didn't put this into a dashboard. So I can work on whatever drugs are removed, we can remove out of this, and then I can provide additional information for the drugs that are selected. So it's more narrowed. But again, this is kind of just an overview of the patient survey information that was provided to us. Is it, and for our first time around, I definitely learned a lot with this collection and would definitely improve on a couple of things going forward. So before I move on to the next slide, yeah.
Oh, just one more I mean, this is great. And to me, it's just like almost, signifies like a signal from the population of like what drugs are like of highest import from patients. So that's one of the big take homes for me.
And I guess I would echo that sentiment that what I think this shows us is that these are drugs that people walk into the pharmacy and they see them. It does tell us which ones are most impactful to those people and the fact that they're willing to speak up about them.
Yeah, exactly. Thanks, John. No other questions, hands I see. I'm going to go on to the next one. So this slide, just real quick, is the drugs type. So if the drug was covered under Medicaid, Medicare, or the private insurance, and if the drug was covered under that insurance. So in the top left quadrant, it says no. So 3 individuals from Medicaid said that the drug that they were offered was not covered. And again, we will provide more detailed information as best as we can into the material packet. So if the drug was not covered, it would be stated in the material packet. Again, I just wanted to provide like a high level before we started with the other drug reviews, so you kind of have a concept of what patients are saying with these drugs. So 21 said that under Medicare, the drug was not covered, and 26 under private health insurance, the drug was not covered. And then here on the bottom right corner was the yeses, with Medicaid showing 15 of their drugs reported being covered, 126 under Medicare, and then 62 under private insurance. And again, we did get some responses where nothing was reported, or it was unknown where if the drug was covered, and most of those were associated with PAPs. Before I move on, any questions on this slide? Or okay. Again, ARC's covered by insurance by type of drug. So Eloquist, it shows that 57 individuals with Medicare had the drug covered. Ozempic, so this is kind of a high level of those coverages. And if no questions on this, I'm going to move to the next slide. Not seeing any hands. So this slide represents the drug covered under insurance and the drug not covered under insurance based on the number of responses by the drug. So again, we had 72 indicate that the drug was covered under the insurance, with 7 saying it wasn't. And then, so again, with Eliquis being our highest rated or highest reviewed drug, and then it just kind of went down from there. With just pointing out that Manjaro was the one that often showed it was not covered under insurance. These ones, the slide is regarding if the patient was on a patient assistant program or if they were not. Eliquis majority were not on a patient program, so they provided no assistance for the cost of the drug, with quite a few having being on patient assistant programs. And that is the end of the slides just regarding the patient survey. Before I stop and go on to the next topic, is there any questions about this information? All right.
Courtney, I don't have any questions, but again, I wanted to lean into what Mr. Murray said, that this does help us even just at a glance see the kind of feedback that we're getting from the community, and the feedback from Oregonians and their lived experiences is very meaningful to us. So thank you for the staff and team's work on that.
Yes.
And for all the Oregonians that help provide us with information to help support these surveys.
Thank you, Chair Bailey. I'm going to share my screen again. In the packet, I included some information regarding the 4 orphan drugs that the board to discuss about removing them due to their orphan designation. Because when the subset list was identified and these drugs were not at the time identified as orphan drugs, we did not go back to immediately remove these orphan drugs, and they are included in the data set. So even though these will eventually need to be removed, I did just want to touch base with the board regarding the information regarding their designations. So again, drugs that qualify for the orphan designation, the FDA approves 2 categories: a designation and an approval. These drugs are all designated, and I provided the dates of their designations, and then I provided screenshots from the FDA website indicating what the designated treatment was for. Just in this sense, where majority of the treatments that incorporated cost and claims were associated with the treatment. So like Botox primarily treated migraines, Humira and Reliquest was, or Ronvig is for like anti-inflammatory and stuff like that. So as the board kind of looks at these designations and considering, you know, the impact that, even though our statutory requirement says we cannot review drugs or select drugs that are cost impact as orphan designation, just taking the moment to look at some of the data information that was provided about how these orphan drugs are impacting the system or patient out-of-pocket cost. So Chair Bailey, I see your hand up.
Well, I wanted to make sure you finished your comment about having us look, but while we're looking, I did have a comment I wanted to make.
Yeah, I'm pretty much wrapped up with it. I just wanted to just provide the overall information that yes, these are 4 that were identified as orphan designations. I did try to provide additional information why the FDA's indicate, I mean, this one was back in 1984 as a designation for Botox, and it still continues to hold its designation now, which is again preventing the board from being able to review it as an impact to the system or patient out-of-pocket cost.
So I know Mr. Judge has his hand raised, but I will make my comment and then we'll give the floor to Mr. Judge. One thing, I guess, in looking at this and looking at the data that maybe we could either briefly discuss or put on a parking lot for us with legislative recommendations towards the end of the year is, Courtney, am I understanding what you're presenting to us today, that if we had a discussion or made any suggestion about changing the language from designated to approved, that would allow us to review more drugs if we're only focused on drugs with approved orphan status, or we're only focused on removing drugs with approved orphan status?
Yeah, I mean, that's the solution that the board can have a discussion on.
Yeah, that was
kind of
just,
thing.
but Mr. Judge, I see your hand was up next.
Thank you, Chair Bailey. Just a kind of a reminder and a clarification. If there's of this list, there's, these drugs have orphan designations, but they also have kind of non-orphan drug utilization, right? So we're saying a single designation on a drug would remove the entirety of the drug from an affordability review. And is that because we can't get to designation in our data?
Yeah, according to the language in our statute, it says the board cannot review or select a orphan drug as unaffordable due to its designation. However, many drugs can be designated. It's the approval that's the ones that are actually approved for designation are the ones that can possibly be like not reviewed by the board.
Right. Thank you.
Yeah. And Dr. Hartung, I see your hand up too.
I guess my opinion here is that if we make a recommendation for the legislature to modify this, I think we should just eliminate that because of this issue of drugs can have a designation, or they can have an indication for an orphan drug designation as well, but they can also have any number of non-orphan indications that they're being used quite broadly for that could have large impacts in the population. So, and I think, in the affordability review process, we have the discretion to consider this. So I feel like it really ties our hands at this early stage to even just say, okay, it doesn't even need to be approved for the designated condition, just needs to have this designation. And then we just can't look at it. So it just seems like it undercuts our work before we can even look at it. So I'm of the opinion that we should just remove that, or we should make a recommendation to remove it altogether.
Remove these drugs altogether?
Well, no, just, what this is what it is. We have to take them out because it's in the rules that it just has a designation. We can't review it. So that's fine. No discussion. But if we make a recommendation for the legislature whenever they're, when they're back, I strongly suggest we just remove this preemptive elimination of drugs with a designation or indication for an orphan condition or rare condition, however we want to word it. But that's my opinion right now.
Gotcha. Chair Bailey, I see your hand up.
I fully agree, and I think staff was aware of that related to our statute. She just wanted us to see it, but obviously it's for another day. But for my peers here today, I was just kind of throwing that out there related to what we may want to talk about to give us more things to look at for future years. But I'm fully in alignment, Dr. Hartung, with what you suggested.
So with that, those drugs will be coming off due to our current language in our statute. But I am actually going to have Heather come forward and start getting ready to share her screen for the dashboard discussion for the review. The intention of reviewing these drugs again. I'm sorry, Chair Bailey, before I go, I see your hand up.
Well, thank you. This was the time I wanted to just lean into this. Can you, before we start diving into the dashboard, just for all the board members here today, can you just remind all of us here the difference between who reports into APAC, who reports into DPT, and what the differences might be? Because I know all that funnels into our dashboard, and I just thought level setting might be very helpful to board members as we start going through the dashboard. Or maybe that was part of Heather's plan all along. So if it was, I apologize.
I can provide a kind of a brief overview, and then whenever I don't capture accurately, as Heather shows the dashboard, we can clarify information. But so the data call information is additional information that we got from the DPT regarding carrier input for the top 25 drugs. And so that was what drove the subset list. From the subset list drugs, we sent back the subset list to the carriers to provide additional information. The data call information is from 11 carriers that report in to the Drug Price Transparency Program. These carriers provided more accurate information or more detailed information around each of the drugs. So there's going to probably be a little bit difference because some carriers didn't report maybe something on a drug in their listing as a greatest increase, most prescribed, or most costly at the time it was coming into DPT. But now that we're collecting them across all of the 11 reporting carriers, there's going to be some differences in claims and costs and stuff like that because we're collecting it unifiedly between all carriers in the data call information. With the APAC information is from all carriers, insurers that report into for the state of Oregon. And so that's quite a few different, I think there's like 20 or so that report into APAC overall, not just the 11 that we collect information from. So the APAC includes Medicaid, Medicare, and commercial. The data call only had commercial. So there is some difference. The reason for the difference between APAC and the data call is to show what's happening within the system, with the data call supporting more what's happening in patient out-of-pocket costs. And then APAC is based off of the gross amount, and the data call is based off of the net pricing, or net cost. I think those are the key things. Heather, am I missing overall before we jump in? And I might add more as we kind of like start showing the dashboard. I'll probably recall like a lot more information and let the board know. But I think for a level set, there is going to be quite a bit of differences from what the original subset information was to what it is now, because it's collected across all the reporting carriers, and then what the APAC information is, because it's cumulative to all the system and not just based off of the 11 reporting carriers. So before I continue, any questions from board members? And then if not, then I'm gonna have Heather show the dashboard and we can start kind of looking at some drugs.
Thank you, Courtney. I think this was very helpful as a refresher, so I appreciate it.
Yeah. So Heather, I'm gonna have you share your screen, and then I think I'm gonna have Heather provide just kind of an overview of, I know that I've kind of touched base with all the board members and just kind of looking at the data, but just for a quick kind of overview and reference, Heather, go ahead and discuss the navigation menu and then each of those sections just briefly. Oh, and we can't hear you, Heather. I can't. I don't know if anybody else has a hard time hearing Heather.
I cannot.
Are you able to hear me now?
There you go. Yes. Hi.
Okay. Sorry about that. I just want to confirm that everyone can see the dashboard itself.
Yes.
It's a little difficult to see what's specifically sharing on my side. So, and again, I noticed that there are some difficulties in seeing raised hands. So if Courtney, Melissa, if you're able to help with that as we go through this, that would be much appreciated. So with the opening page, the navigation menu, these are all active buttons that will allow you to navigate to different places within the dashboard itself. The names of the buttons are hopefully indicative enough for us to navigate to the potential page of interest. The dashboard instructions are basically using the filters, using the what abbreviations mean. You'll see acronyms and abbreviations over here, and then a brief description or some key points for each page that is listed in this dashboard. You can at any time return to that navigation page if you'd like to see a different page or go somewhere else. You can also navigate from the bottom of the screen and go chronologically through them as they are listed in these buttons here. The first, excuse me, and the first data focused page would be the drug lookup tool. This is singularly focused on single drugs. And you will see that Ajovy is a default alphabetically here, not for any other reason. And you'll see side-by-side comparisons from our data call, again, which was net, versus our APAC, which is gross and again includes commercial Medicare and Medicaid. You'll also see some price concession information and some CCO information, as well as plans represented by our data call. And then over here, you will see some out-of-pocket costs from the data call, as well as some basic information about those WAC values that were included based on NDCs. And up here, you'll see the therapy class. You can select a single drug as you go through. These are only inclusive of the drugs that are currently on our subset list. You can also filter by the APAC claim line of business, which is the commercial Medicare, Medicaid, or by payer type. And this is relevant to our data call market types that were pulled information from the carriers. Moving on from the drug lookup tool, you'll go to the drug lookup summary. Again, on the left, you'll see the prescription drug names. These are relevant only to our subset list. You have the option to select by therapeutic class and or by prescription drug name. This is defaulted to a commercial filter for APAC. However, you can change that through the filter as you move through it. And as you filter, you'll see the number of represented drugs fall across this page. The next page, and please stop me if I am going too quickly at any point.
Yeah, just real quick, Heather, I just wanted to verify on that page that that is the accumulation of both the insulin products that was selected and from the subset list. That's why that number shows 36. So it's both of those lists combined. And then I did want to just note that due to some feedback from board members, we did make additional columns to kind of help with down to the per paid and claims today. Again, apologize that we had to include that, but we wanted to provide as much information to board members to help with this decision-making process when you're looking at it. So I appreciated all the board members who helped kind of provide additional guidance for the staff to make this as meaningful as possible. So Heather, if you can go on. Oh, Shelley, I see your hand.
Courtney and Heather, thank you for adding the columns here. I think the other place for future meetings it might be helpful on is on the previous screen that Heather was showing, where you can look down by drug and therapeutic alternatives. It might, gosh, it might be one of the other screens. Sorry, I'll go back later and look, where we could also share it broke down that way related to the therapeutic alternatives.
We did add it to there too. I was going to make a comment in that.
There you go. Okay, we're not there yet. I appreciate it. Wow, that's amazing. Thank you.
Yeah.
Look.
Right. Thanks, Heather.
Any other questions before we continue? Okay, going back to the screen. Yes, we did add a few columns this morning based on feedback received. And this is inclusive of both the subset and the insulin drugs. The next page that you will encounter is it's a basic NDC informational page. You'll see multiple occurrences of a subset list drug name over here, but the singularity lies in the NDC. So for example, there were 3 NDCs of Ajovy represented in our data set for the subset list, and therefore there are 3 occurrences of Ajovy on the left-hand side. You may filter again by therapy class and prescription drug name. The next page is the first page focused on alternatives. This is based on APAC data. And you will see first the subset list name, and then you will see the if you expand this out, you will see the therapeutic alternative, equivalent, or biosimilar. Alternatively, you can fully expand the list by clicking on these double branching down arrows, which will expand each drug independently in association with all of its associated therapeutic alternatives. Clicking the up arrow will collapse the list. When you do that, if you select a particular name, you will see it isolated over on this side. You can also click to deselect it. Additionally, for example, if you wanted to focus on a particular therapy class, you can do that, and the graph will adapt to that based on your selection. Moving on to the next page. This is a side-by-side comparison, also using APAC gross level data between our subset list itself. So you'll notice there are no expansion errors because this is singularity for each drug on our list. And over here, you will see that drug name and its associated TAs, TEs, or biosims next to it and underneath. Each graph is reflexive based on the filters you choose. So again, if you were to check, I'm just picking on this for no particular reason, just for the purposes of example. This drug, you will see that both sets filter by that selection of therapeutic class, and you can hover over the different data elements to see what those actual values are. And again, when you see this plus sign, you may either expand by hitting the plus sign or the double branching arrow, which will expand everything in the category, and collapse by hitting the drill up arrow. The green indicates the filters that are available for, and it says TA, that's an abbreviation for therapeutic alternatives, equivalents, and biosims. If you'd like to select by the commercial Medicare or Medicaid or alternative, the payer type, it will only focus or drill down on this side of the equation. Alternatively, if you want to do the same thing on the subset list, you may do so using the same filters, although applied to this other data set on this side. And you can clear all filters at any time. You can do this, or you can go up here and click those. Just to reference these buttons at the top, these are active buttons. You can return to any of those pages indicated as you navigate through if you would like to revisit any of those pieces of this puzzle. The next is focused on plan design. The upper graph is focused on the 6 that were recorded in the data call. Remembering or recalling that the previous 2 slides were focused on APAC data. This is focused on data call versus net values. There are 6 plan types represented by each of the green dots. And down here, you will see all of the drugs represented based on minimum and maximum average cost as reported. You can, again, filter by therapy class. It will alter this graph, this table and these graphs according to whatever filters that you choose to select. And again, you may clear those at any time. The next one is also focused on plan level design. However, this one is focused by market. Individual, large, and small groups were those that were reported in our data call. If you were to, for example, again, sort by, we'll use a different one this time, a therapeutic class, you will see the graph will react to your selection. The upper graph is plan spend per enrollee as reported based on market, and the below graph is out-of-pocket cost per enrollee based on what was reported per the market. And you may clear those filters this way, or alternatively going to clear all filters. The remaining and final page is based on price concessions. This table represents all of the drugs on our subset list, to include insulin drugs as well. This is a 31.5% price concession averaged across all of the drugs. When you filter, this will reflexively change, as will all of the numbers on this side. The pie chart represents the breakdown of those price concessions, purple being manufacturer, yellow being PBM, and the gray being anything else other than those indicated by manufacturer and PBM. So again, you may filter by drug name or therapeutic class, pick a different one down here, and you will see isolation based on your filter. With that, that's the very broad overview of how to navigate this dashboard. Are there any questions before any discussion continues?
And I just wanted to point out to Chair Bailey, before we dive too much into discussion or review of the drugs, we may want to take opportunity to take a break for a few minutes and then
Good point.
we can come back and kind of dive more into this stuff. But I wanted to
We're exactly on time. I do want to reference, so I see that, well, Mr. Judge had his hand raised, I guess it's down. Mr. Murray, before we take our 5-minute break, do you have something you want to say in advance of the break?
I do. Thank you. I want to apologize first for being late to the meeting. We have just one backbone of fiber into our valley, and a backhoe is a really hard implement to use on it. So I had to go adjust to our pharmacy's emergency backup. So I apologize for being late. But in being late, I didn't declare my potential conflict of interest that I normally do, and I would like to do that now as an owner of Murray's Drug with contracts with them. But I also need to report that on May 27th, I provided testimony to the informational meeting of the House Committee on Behavioral Health and Healthcare in support of the -6 amendments to House Bill 3212. These are requirements, and I apologize for being late and missing those. So thank you.
Mr. Murray, thank you for sharing that information with us now. The other thing that we did is we moved the vote to approve the minutes to the end of the meeting. So you'll be able to participate in that as well. So with that said, I will take Courtney's guidance and we will go ahead and add our 5-minute break right now. And so I guess we will be starting around approximately 10:34 a.m. Pacific. All right, welcome back, everyone. Melissa, if you could call a quick roll just to confirm that we have all board members here before we advance our discussion.
Chair Shelley Bailey.
Present.
Dan Harten.
Present.
Lori Hoagland.
Here.
Robert Judge.
Present.
Chris Lehman.
Here.
John Murray.
Present.
We have a quorum.
Thank you, Melissa. Courtney, the floor is yours.
Thank you, Chair Bailey. I think Heather will be joining us to share her screen again, and then we can start off. I did want to take a moment to go back to Robert since his hand was up before I went to break. Oh,
Thank you. It wasn't reacting. So,
it's okay.
so quick question on the toggles when we were in kind of where we can select like a payer type or a therapeutic category. Is there a way to toggle on multiples? So my consideration is Medicaid is like its own animal, but I want to look at carrier spend, government spend in aggregate and carve out Medicaid. Is there a way to do multiple toggles?
Are you referring to those that are associated with therapeutic equivalents and alternatives as well?
Well,
or just as a
yes.
drug? Can you go to the next slide maybe? Because this is only for individual. That one. You can select go to prescription drugs. You can select various drugs here, and then you
But can you
do
select multiple of them at the same time?
Yes.
Yeah. So you
Okay,
can select
thank you.
various drugs here.
Mhm.
And then if you wanted to look at so this is based on commercial right now. So Heather, if you can throw that maybe over to Medicaid.
Okay. It must have been, it must have been on one of the tabs that I was on that I wasn't able to do that. Okay, thank you.
Yeah.
The only filter that is a single select is on the drug lookup, which is because it's focused on a single drug here.
Sure.
The rest of them, you should be able to select multiples.
All
Okay.
right. So before we start diving in, is there any other questions about the dashboard or drill downs or anything? Or the next question is, where would the board like to start? Do you want to look at the drug level summary of all the drugs? Do you want to look at drugs based off of therapeutic class first? Do you want to look at insulin products? I know I'm throwing a lot at you, but am hoping to get some decisions. Yeah, Chair Bailey.
Courtney, since we have many of them on our list, I think let's start with the approach to insulins because I think it's very apparent we need to pare down that list. So let's just start with that and then continue from there. Keeping in mind, we must allow we can't let insulin take over our whole discussion, but I would like to lean into that getting started.
All right, sounds good. I guess to start off, and Heather jump in for some guidance on this, but if you look at the Basaglar Tempo pen, there is limited or no data call input because no carriers covered or had a claim on this drug. The information in APAC is pulled from APAC, which means that somebody outside of the 11 carriers that report to DPT and to PDAB reported on those. So the only thing you can look at that is possibly a system impact. I'm not sure if that's something that the board's interested in continuing to look at, or since there's no data call information on that for additional substance claims and costs, if that would be a drug that the board would be interested in removing. Additionally, if you look at the the Rasblar quick pin, very limited information was provided. Again, it's not only one carrier reported on this drug compared to the 11. Yes, Dan, Dr. Hartung, I see your hand up.
I was under the impression we were going to just review the entirety of glargine as a whole and not, in its own affordability review, all the different flavors of glargine.
So again, it's coming down to the statutory ask is to identify, at least one insulin product. And within an insulin capacity, there's 9 here. So we'd have to develop 9 packets or 9 bits of information, staff would, to show the comparison across. If we could remove a couple of them that may not show as great as an impact, then I think it's a little more meaningful. But this, again, it has to be a board's decision on what is the most meaningful to identify an impact from the insulin products.
Well, I think I think that this review packet is going to be different than the other ones because, we have multiple biosimilars, some are interchangeable. And I feel like focusing, some of these, obviously, we have 32 people in APAC statewide. So obviously, I think that could be dropped, but and we don't have any net pricing information from the data call, so we're a little bit limited there. But I guess I feel like this whole category should be in its own standalone review, and the review packet may look somewhat different than the other ones. In which ways, I don't know, but to me, I feel like if we eliminate some of these things, we're going to be wondering, well, how does Basaglar compare to some of the other, biosimilars, things like that. Again, I'm not a content expert in this area, so limited here.
All right. Yeah, Chair Bailey and John, I'll have you go before I kind of provide some insight to some of that. John, I see your hand up.
Yeah, I guess I was one who spoke up also in one of the last meetings about including all of them. And I guess I'm hoping that they could stay in there, maybe with the exclusion of Basaglar, because there is very little information, but hopefully the packet, as far as, the base information on each of these meds, is really the same. So really the difference of information coming to us would be availability or pricing or cost per patient, that kind of stuff. So hopefully it could be somewhat abbreviated, but still bring us that information. I was really hoping to see the idiosyncrasies in the marketplace in the terms of rebates and those kinds of things on this class, I thought it might highlight that aspect of it, why some are on formularies and why some are not, and how are the rebates tied and where the rebates go and that kind of thing. So really, I'm hoping that they can stay.
Okay. Chair Bailey?
So a devil's advocate perspective here would be, I was in the same mindset with Mr. Murray and Dr. Hartung about looking at the entire class. But as I drilled into it more, I was curious. I think removing the generic insulin glargine makes sense, because I think in previous meetings we had even referenced that we would remove generics. Also, looking at the Basaglar Tempo pen, as well as because there's very limited data on it, as well as the Resglovar, just because the number of enrollees is low. I appreciate both of your sentiments that this could be maybe somehow a combined packet, but because they're different trade names and different companies, I would still want to be very mindful of not asking staff to prepare these. Even though we might see it as a total universe, I would suspect other stakeholders may not see it as a total universe. So those would be at least 3 suggestions I would make for ones, not to suggest they shouldn't be part of discussion somewhere, but just looking at the sample size, something being generic and limited data. Those would be 3 that I would advocate to not dive into more fully as we advance these reviews.
And I guess I would argue against removing the generic insulin, only because I would like to see it in the total picture. I understand, and I'm sensitive to the amount of information that needs to be gathered, but my point, I guess one of my questions is, why are brand name drugs still on formularies at preferred pricing for some plans? I would like to know why that is and follow the money. I'd like to see the rebates. I'd like to see where it's going. I'd like to see why, which one's the most used, Lantus SoloStar, for example. Where's the money going and why? Why isn't the generic being used? So that's the kind of stuff I kind of want to see from this approach.
And John, some of that might be too detailed for the information that we have collected. Heather, can you go to the price concession and pull out insulin, please? So I want to make sure that we're at least trying to capture what you're wanting, to see if we can get to that granulation. And if it's the board's choice, we can, set everything up to include all the products. The only thing is then we'd pretty much have 1 month dedicated to only, to review only the insulin products for a meaningful discussion, which means that a lot more other drugs will have to be reviewed in the other 3 months. So we'll have to figure out the timing of some of these buckets and everything after we've kind of had a conversation around this, but I see many hands up. So I think Chair Bailey, you're up first.
Okay. I hear what you're saying. I hear what my colleagues have said. I still feel when you look at the net price on generic insulin glargine, although I'd like to see everything at full scope, I don't know if personally looking at this information, I would suspect that insulin glargine is leading to affordability challenges in Oregon, the generic. But that's just my opinion, trying to make sure that we have time to review. We have a manageable amount of drugs under review.
Thank you, Chair Bailey. Yeah, that's the thing, is what is manageable for the timeframes that we're kind of up against. Robert, I see your hand up.
Yeah, thank you. So I'm inclined to go where Chair Bailey is thinking. I always think generics over brand any day, because that's where you get to the lowest net cost. However, I think John brings up an interesting point, because if I think about net cost, I'm not quite these paid amounts per claim. Are those at the net cost? So you essentially have already factored in the value of rebates into what we're seeing there. And if that's the case, then that's a little head scratching because APAC, which doesn't include rebates, is almost equivalent or higher in some categories, which is really kind of, I'm just scratching my head on how to interpret the data. We have paid claim net of rebates. We have APAC data with no rebate values, right? But they both feed into the utilization of claims. So we can't parse those. No, I guess we can't parse those out. So, okay, I'm back where I was with Chair Bailey. I think generics over brand any day. So that ought to be removed. That's an easy one to remove.
Okay. Dan Hartong or Dr. Hartong?
Yeah, I mean, this comment is more just overall kind of what we're targeting here, and we're trying to reduce the number of drugs to go through the affordability reviews, and I guess this also reflects some just public comment that I was hearing, as well as my own concerns about when we get into these affordability reviews, what are we going to be doing? Like, how are we assessing it? We haven't even, I don't think we've had as a board a discussion around our mandate of understanding what affordability is and making these decisions. And I have concerns we're going to get these reviews and we're just going to be kind of making a lot of subjective assessments without any sort of landmarks to guide us. What is affordability challenges in terms of like what is high out-of-pocket costs for patients, what is high net expenditures for health systems, and so my bias is to review a very small set of drugs, but spend a little bit more time thinking about these issues that we're supposed to be identifying, because we're going to be doing this conceivably next year as well. And so I'd like to spend more time on process and less time on just going to, having an extensive drug list. So that's kind of my thought on this. And so I feel like this glargine issue is, I'm fine having one whole meeting devoted to glargine. I think it's a big enough drug that we can spend a whole thing on it. And then, but I just want to make sure the process is, we have a shared understanding for how we're thinking about these larger issues, because we're kind of heading very quickly into this without, I think, at least good guidance on what we're supposed to be doing in terms of identifying affordability challenges.
I do have a response, but I'll let John go and then I will provide some response to that.
I'm going to speak from my perspective as a community pharmacist. And, I stock these glargine products, all of them, because I have to, because one plan puts it on as a preferred drug over the generic, for example. If we're going to try to assess whether it's affordable or not to the patient, and I want to know about the plan, how did the plan make it affordable? What's going on behind the scenes? If we don't have that data, that's too bad. I really would like to see that and how we get to that. How does a plan justify spread, for example, and rebates to pay their PBM bill at the cost of all the other Oregonians in the state? So I'm going to be focusing on that, affordability to the patient and to the plan, but I want to learn from this. So I hope we have the data to get there.
So, and just in the interest of time, because we have a lot of drugs to go through, if it's in the best interest of the board to go ahead and just review glargine, just know that it will be for one meeting in itself, which means that more drugs will be under review under other months. You don't have to vote on that right now, but that's kind of what I'm hearing is that this is the preferred, unless the board unanimously says you want to remove the 2, 3 or so that really aren't showing an impact to the system or patient out-of-pocket costs. And Dan, just to I know the charge is to consider what may be an impact to the system, and really this isn't just based on affordability, it's actually based around kind of a cost review. We're looking at cost impact from information that was provided from us, from the carriers and through the system. So, but we are provided the guidance through our rules that the board voted on and our statutory requirements. And that's the important part about like our rule -020, which includes the dynamics of the statute, which is to determine, you know, price concessions and what's going on with the systems and those kind of things. So we do have some guidance. The thing we're at now is we need to select this, or the board needs to select drugs that can be compared into what all those data points are. But we have to do it in a very small amount of time, but we really want to do it meaningfully as well. So with that, again, fine taking all the glargines and putting them in, we'll have 1 month. And then we can determine what drugs would be most meaningful, or to actually remove off of the drugs that don't show to have an impact. Because we're down to literally 60 minutes to decide on a much larger scale of stuff. So Chair Bailey, I see your hand up.
Well, that's in alignment with what I was going to say. When you look at the total drug cost of this class versus some of the others, just for the record, I am exceptionally uncomfortable devoting an entire meeting to insulin just because of the time lane to meet our deliverables. So I guess I know we're not voting on it right now, but I would just ask board members to really think about it. And at the end, maybe vote on it. But I think because these are made by different manufacturers and different things, I see it as almost impossible to have like one, we can't treat it like one drug, right? And so I just want to be very mindful of staff resources and board resources as we go through these discussions for this year.
Thank you, Chair Bailey. So I guess with that, until additional information is provided by the board, do you want to take a look at some of the therapeutic classes that have multiple drugs on them? We could start with.
So Courtney, maybe before we do that, can we kind of have a quick discussion just as a board about like a few things such as drugs that have been, or drugs that are on different IRA lists, or how we want to handle those things before we even drill down at the drug level? Or do you think it's better for us to look at it drug by drug? Or I guess that's a question for my peers, really. I mean, do we want to have that strategic discussion to help us be more efficient with this remaining 60 minutes? Because as a board in the past, we have considered removing drugs that are on IRA lists, but I think we should talk about that and spend no more than 5 minutes on it, because that'll help guide us through this process, because we do need a vote on this today. So with that said, does any board member
wanting the board to look at drugs that were on the IRA?
Well, I'd like to have a strategic discussion as a board as to if it is the will of the board to still look at drugs that are on IRA lists, or would we prefer to remove those drugs because other stakeholders are looking at it for other purposes? But I think that's a strategic discussion that board members that we should probably have together.
Okay.
So, Mr. Judge, I guess I opened that door. You're walking through it. So,
well, yeah, I mean, I struggle with trying to find a compelling reason to investigate drugs that are on the IRA list. Is there a compelling reason?
I'll let others speak before I give my opinion, because I'm so free with my own opinions, but I'd like to hear what others have to say, and I could then chime in. Mr. Murray, you're laughing, but you have the floor.
I would agree that the drugs that are on the IRA list probably are going to be dealt with by other agencies that have far more power than we do.
And again, just for clarification for people listening, this is just a discussion to look at what drives costs and affordability. We don't make decisions beyond that. But other board members have thoughts related to diving in further throughout 2025 on IRA drugs. Ms. Hoagland, your hand is raised. You have the floor.
I share the same opinion of removing those.
Are there any board members who feel differently? Because this can help us with our next steps for this discussion. Dr. Hartung.
Well, my sense is that if we do that, we're going to probably reduce our current subset list by half or so, I would say. I think it's the IRA negotiations have yet to be rolled out in terms of actually implementing those maximum fair prices. So I'm less inclined to remove them. And again, I feel like this whole first iteration is going to be more, to me, is a process related endeavor rather than actually, because we don't have authority to do anything. It says just evaluate affordability and system challenges. And I think we can do that with what's in our list currently. So I tend to think we should just leave them in.
Thank you, Dr. Hartung. I guess maybe with that said, then, do any board members have any thoughts related to the drill downs or certain drugs you want to start talking about? As we do have to frankly pare down the list. But Dr. Hartung, your hand is raised, so you have the floor.
I'm wondering if we can think about like how much time we have and what would like a reasonable amount of time for staff and for meeting time to like to tackle these reviews, and then use that as like the target number. If we think we can get through, 8 or 9 drugs, then we just say, let's just try to target the 8 or 9 highest priority drugs, either by spend or utilization or something like that, rather than trying to engineer some other approach using different criteria that we can query on the dashboard and things like that.
So with that said, do any board members have any thoughts related to certain drugs as you went through the dashboard? I mean, I can personally share. I have some thoughts and I'm happy to help kick us off, but are there any drugs that, as everyone has looked in the dashboard, you believe just kind of jump out at you as things that we might want to remove? And if you don't have that, I'll start going through my own list. Okay, well, I guess I will again, this is just my own thoughts, not being a data analyst. Is the first drug that appears on our dashboard, just because it is alphabetical by name, is the Ajovy. I apologize that I'm probably botching the pronunciation of that drug. I spent my time looking at what the ultimate cost per prescription was, both to the payer and to the enrollee. And I did some of this before we had an updated dashboard, but what I found personally in looking at that list was that that drug specifically actually has a lower dollar amount per payer, and a patient pay amount that's kind of in the middle of the patient pay amounts. So from that perspective, that would be a drug I would remove, because other drugs in the class drive higher payer per claim costs.
And so Heather, can you pull that out to the?
Sorry to start just whipping this out. I just wanted to help advance.
So Heather, can you look at the therapeutic class for Ajovy, please?
And this could be a spot where, not that staff is deciding, but staff is helping support simply because staff has seen the data more. And so if my assumptions are inaccurate, please correct me. because I was doing it by hand before some of these additional columns came out. But I was, yeah, so that's 637, I got 636, so apparently we're close on that. And
Ours is rounded, Chair Bailey.
no, I know, I was joking. But I was looking at that, and just kind of what jumps out to me is that it doesn't, I wouldn't have put, now seeing this information, when I look at pay or pay per claim, it doesn't make sense to me that that drug would be on the list. That was the methodology and way I was looking at things. But I'd welcome staff ideas or ideas from my colleagues. Dr. Lin.
Yeah, thanks, Chair Bailey. I think back to maybe a previous point that Dr. Hartung was trying to make, I feel like if we all had an agreed upon sort of metric, and then we could use that to say, and maybe this is the metric, like total payer, like total amount paid per claim, and then use feedback from staff who may say, hey, we feel like we can do 15, or we feel like we can do 12 of these packets for you guys, to kind of then say, okay, this is the metric. Let's take the top 12 or the top 15 in that, whatever it is that we're going to all agree upon to use as the metric, so that the staff have time to actually give us full packets and reviews for the meetings. I don't know, does that, and I'm not saying, yes, this is the metric, or no, this isn't the metric, but we could agree upon something and then filter it down to just that list. Does that make sense?
Certainly makes sense to me, and I do apologize because I have had meetings with staff, so I believe we really need to get ourselves to a total number of around 15, but that's something we should talk about as a board. But Dr. Hartung, your hand was raised first, I believe.
Yeah, I mean, my comment is, I agree. I think we should look at the time we have and the bandwidth of staff to figure out what this magic number is, because I'm very comfortable reviewing a smaller number of packets and doing a really thorough job of it, because knowing that we're going to be doing this again. And so I think there's going to be a lot of learning during this first process. And if we don't get the 9 or whatever the thing is, I'm fine with that, and just being really confident in kind of the process.
Mr. Murray, your hand is raised.
Yeah, I'm wondering if we could take the approach that we choose, because I want to focus on the patient out of pocket, but I also am sensitive to the expense to the plan. And I threw this out when I spoke to someone about what would happen if we selected the top 5 or top 6 drugs on our list that are the most costliest to the plan, and the top 6 that are most costly to a patient out of pocket, and we worked from there. Just spitballing here.
And Ms. Hoagland?
Well, I wanted to also bring up the concept of therapeutic classes, so that we make sure that we're looking at a broad spectrum of patients, rather than just looking at, we may end up with many more medicines treating one group of patients.
And that's in alignment with the personal work that I was doing, was I was pulling each of the drugs and then looking at the DC payer paid per claim and looking within that therapeutic class. So I'm in alignment with you on that. Mr. Judge.
I'm kind of lining up where John is. When I think about, how to sort through a very long list of drugs with lots of data, I think you have to look at total costs, to the system, and as a starting point, and then get down into kind of where it burdens in terms of the plan costs and the member costs, and then determine whether there's alternatives in therapeutic alternatives. So that's kind of how I'm thinking of kind of a sorting mechanism to get to the magic number of drugs. And I'm kind of aligned with Dan as well. there's nothing wrong with starting small.
So I do not disagree with anyone. Again, that was when I was personally doing the drill down on each drug. That was actually the logic I was taking. I was just not looking at it per drug at the global level. I just went to each drug, then looked at the drugs in the therapeutic class at the DC payer paid claim amount, and then thought we would also filter against patient out of pocket. But with DC payer paid claim amount as the first driver. But Ms. Hoagland, you have your hand raised.
I guess for clarification for this year, we have to do 9, right?
We have a legislative mandate to do 9. And so my target in communicating with staff was that we would leave this meeting here today truly with no more than 15. That was because obviously we know as we go through the process, we don't want to end up in a position where we have such a limited universe that anyone feels like they have to vote one way or another based on the total numbers that we have to meet for our legislative mandate. Dr. Hartung.
I mean, so my I'm just going to emphasize my concern is just we get into those reviews and we're all going to have differing, which is, I guess, is fine. But we just differing opinions about what is affordability in terms of patients and affordability in terms of health systems. And we really haven't had any sort of, that I can recall, any sort of discussion about what that is in terms of like quantifying it. So
your earlier point, I mean, maybe if we could go back, Heather, to the sheet, the spreadsheet that had all the claims. I mean, what I just want to reinforce to us is I don't disagree, Dr. Hartung, with what you've said, or Robert Judge or Mr. Murray, but we have to look at that. Even if we have to look at, to your point, Dr. Hartung, I think it was you that said maybe looking at the top, I don't know if you said 6 or whatever, based on payer claim amount and based on patient out of pocket. We do need to have that discussion today so that we can get the guidance as a team for staff so we can advance these.
So real
Chair
quick,
Bailey, is this the page you were looking for?
go to the next page.
There was this kind of a spreadsheet page, but Courtney's clearly far more experienced than myself.
So, and then based off of, I'm sorry, Chair Bailey, I just want to get Heather to where she needs to be. So clear out of this, please, and then filter all the drugs under review by the DC payer paid claim.
Is that Dr. Hartung, what you were, the field you were thinking about?
So then from, look, other way, please. Thank you. So but again, we're going to have to move out Humira, Dupixent, Rinvoq, and Botox.
I guess my concern is we're going to get these reviews and we're going to look at a drug and it's going to say average out-of-pocket cost is $500 per year or whatever. And then we're going to be looking around and saying, is that unaffordable for a patient? Well, for some patients it might be, and I don't know. So it's like we haven't engaged with this notion of what is affordability at the patient level. And there's research into like things like, financial toxicity and high burden of out-of-pocket costs and what that is. But we really haven't had a rigorous discussion about that. And then from the health system perspective, net spending on a drug, what is too much, like what is unaffordable for a health system and from a net spending perspective? And I don't know. And it's like, we just haven't had that discussion or guidance. And so I'm just concerned about getting into these things, we're hyper-focused on the drugs themselves and like less about how these decisions are made. And, in the last iteration of this, it was a little bit, that it was a little bit squishy in terms of like, it's like, well, that seems expensive, but I don't know. I just feel unprepared.
Courtney?
Sure, really. So Dan, and board members, I think a good way to kind of think about this as well It's not, again, there's no definition for affordability, but there is concept with cost. So looking at it from a cost impact can provide the guidance that the board needs. So obviously if a drug, is $48.5 million to the healthcare system and the patients are paying, a substantial amount. Heather, if you can scroll over. So that's Ozempic, and a patient compare anywhere between 82, depending on their plan, to 100 and something per claim. Maybe the concept of cost, looking at the cost and not necessarily affordability. Affordability is such again, the board hasn't been able to find a definition because it's all based off of the rules and the statutory requirements. But the numbers, and with looking at it more from a cost impact, I think that like John was saying, you go from like what is a high impact to like the carriers versus what's a high impact. And Heather, if you can filter maybe by highest paid per claim for enrollees for patient out-of-pocket costs, so that's going to be much different. And again, this is based off of just the data call information versus the APAC information as well. So Perjeta showing patient out-of-pocket costs. Scroll back over, please, Heather. We're looking at 3,796 average patient out-of-pocket cost. So those are concepts to consider and look at that drug from those two perspectives. And you'll still be able to identify your 9 if you select 7 or so drugs from that perspective. And I see lots of hands up, so I'm going to start with my first one, which is Robert.
Yeah, Courtney, that's good guidance. When I'm thinking about affordability reviews, I can't disassociate affordability for patients from affordability for systems, because patient affordability is a function of system costs. And so I think you have to look at system costs and at the top, and then funnel down from there. So my priority would be which drugs are costing, what are we spending the most on? And it might make sense to look at it from a total cost and then a cost per claim, and then kind of the patient burden on that as a way to kind of step our way through a culling list. But we can't disassociate patient costs and system costs.
And Heather, do we have that number in our dashboard where it's the combined patient and payer costs?
In our data call, the total payer paid is reflective of all of the costs rolled up. And then in APAC, it's not as straightforward. It's delineated based on payer and enrollee, differentiated.
So if we focus on DC, the data called, do we have that visible here in this dashboard, the overall?
The total payer page should be representative.
Okay, can you filter largest to biggest?
Yes, that is currently filtered by the data call payer paid per drug.
Perfect. So like Robert, this is what you were saying. This combines both patient and payer out-of-pocket costs combined. So selecting from there, and then we can delineate out from those.
Yeah.
Reasonable, but Chair Bailey.
I mean, I'm not against looking at it that way. I did just want to lean into something you said, Courtney, related to these, really to kind of follow up on something Dr. Hartung said. With the data we have, these are very much cost reviews. And I think that on some of the things that Dr. Hartung was saying we don't have access to. I don't disagree, but when we look at it, we're looking at these as cost reviews. And then when we get to the next step, if we agree as a board to maybe do something similar to what Mr. Judge outlined, then the dashboard has very rich information about the costs of other drugs in that therapeutic class. That's something we didn't have last year, which to me, as I was studying on all these drugs and looking at it one by one, that information is exceptionally meaningful because it is cost driven and you can look at it from those lenses.
Okay. Laura, I see your hand up.
Well, a couple of things. I think if we try to select criteria, like also number of enrollees, impact to enrollee, impact to payer, and select some that we want to do a much more detailed evaluation of, just because we don't have the capacity to look at that level for everything. We are talking about a moving target. So one of the things that we have to face is the fact that we're dealing with 2023 data, and, you know, things change. And so there is some accuracy challenges just in the time frame. The other thing I wanted to mention is the surveys that we did also are giving us information, and are we going to think about that as we're picking the medicines? Where do we put the survey in all this, or have people thought about that?
Again, all information from the surveys we put into the packets once we know what the drugs are to go under review. And so, John, I see your hand up. Okay.
Yeah, just a quick comment or a concern of mine that I always view when I see data like this in our discussion about cost to the plan or the total healthcare system and then getting down to the patient. I always want to see, and I'm not sure our data will ever show it unless it does get into the drug reviews that are more in depth, the distortion that happens between manufacturer and patient. I want to know the ups and downs and whys and wheres and things like that. Just a comment, I'm always skeptical of what happens behind the scenes.
So Courtney, if we're looking at it this way, can we also then, and I know this is something we've done in the past, but can we also then filter against total, and maybe Zoom's just hiding my ability to see it here. Also then filter against claimants so that we can like process claims, just so we could look at how those two filters might line up. I mean, I fully agree with Mr. Judge that payer affordability and patient are linked directly.
I don't know if it's available through the dashboard itself, and I don't have a spreadsheet.
Well, total DC number of claims, right? That's the, okay.
Yeah, I mean, you could sort it by that. But as far as identifying
DC number of claims could
to the payer paid per drug, because if you go back the prescription drugs, and then also just to be mindful that the drugs are also with insulin products, so we'd have to be removing the insulin products to get an accurate listing. Thank you, Heather. And so if you can go back to the highest claim still, so we're still looking at Ozempic, Jardiance. And then if you do, there you go. Thanks, Heather. Oh, is that the DC payer? Is that pay? That's not. Can you make that largest to biggest as well, real quick, just for me to.
This one right here is currently largest to smallest.
Because it got modified when we modified it.
When you set the claim, so I'll just do it on my side. So if we're looking at, oops, we have to move from mirror.
Here we go.
Again, the caution on this when we do it globally like this and we don't look drug by drug within the therapeutic class is this is more reflective of plan design, which is why I had been doing it manually drug by drug in the dashboard. looking at the benchmark possible drug on our list versus the therapeutic class. Because in this use case, I don't see a way to show that a lot of this isn't driven by formulary preference. Mr. Judge, do you see a way to help you?
Well, no, I don't see a way, but I see a comment. I'm not, again, I come out of an insurance background, a pharmacy benefit background, so maybe I'm a little jaundiced in my view, but I don't know how you disassociate formulary from this information, because formulary determines costs in the system. We got the drugs that manufacturers make and have a price, but when you get it through, how do we pay for drugs? The formulary, whether it's a PDL or a formulary, it's the vehicle that's used to determine affordability for payers and patients for the drugs that are dispensed. Now, I understand that there's a rebate component, there's all these aftermarket incentives that may direct behavior, just like in the supply side, there's a bunch of behaviors that influence how costs are actually felt in the system on the buy side. But the formulary is a fundamental part of the system, and I'm not troubled by that.
Dr. Hartung, I have a comment, but I'd like to acknowledge you first.
Oh, thank you. Yeah, I also think some of the formulary stuff can be sussed out during the affordability reviews themselves, and like that's kind of what that process is about. The one caveat with this maybe is that if we're going to use, net paid as assessed with the carrier data here, maybe we also have some sort of threshold utilization, like how many patients are being prescribed in the state as some sort of lower bar of statewide use. We could couple that with APAC number of enrollees or something like that as like a broad assessment of how common it's being used.
Mm-hmm.
Well, and to your point, I guess maybe I've been jumping ahead to the next step, because I guess you're right, Dr. Hartung, you can flesh out plan design when you look in the therapeutic category. My intention, Robert, was just that I don't disagree with you that the price of the drug and formularies are linked. I just don't want to disproportionately end up looking at drugs that may actually be more affordable than their peers, but simply come up because of their preferred formulary placement. But we can see that in the dashboard Heather created for us. We can actually see that very easily in the dashboard. So Dan, do you have a suggested number of claims or to help us with filtering this based on your previous comment?
No, I don't have a number, but I mean, you can, or we can sort this by the APAC number of enrollees, which I feel like is probably the best metric to assess like how commonly these drugs are used in the state. And obviously, so and we can look at this whole list and we can say, okay, some of these are just used by a couple hundred, some of them are tens of thousands, and that impact is quite there's variety there. So I don't know what the number is, but maybe we can use that as like a demarcator.
Are we able to find like a mean in the total number of, again, I am not a data analyst, so
But we
Sure.
can just scroll down the list. You can see, we can
Yeah.
just look visually and see where it drops off. And, I don't know. I mean, it's just a value judgment essentially.
And I'm not sure if this is going to be helpful to the board. So while you're chatting, I did some snapshots. I'm going to still screen, Heather. And I apologize for the last minute kind of show of this. It's just okay, what I'm showing here, this is drilled off of the DC payer paid amount. We're showing Ozempic, Concentrix, all these lists to this line here. This is based off of APAC payer paid. This is what Dr. Hartung was just saying. So you have some of the same drugs on each side. So the board can decide if they want to take the APAC list or the DC list or have a combination within those. You have, again, Ozempic, Concentrix, Trulicity is not on the APAC list. Jardiance is. Tremfya is not. Ocrevus is not. So something along that for an idea.
I think that's idea, Courtney, or maybe we see what's on both lists, but I do think as a board we should probably, to Dr. Hartung's point, do we want to talk about our guiding light related to like number of patients, or I guess we have this as number of claims. So do we want, am I hearing us correctly in saying and that that would be one of our points that we're looking at. But Ms. Hoagland, your hand is raised. Do you have the floor?
Yeah, I also feel a number of patients is very important, as well as some representation from a variety of therapeutic classes. And then as we're drilling down based on the cost, I think we could eliminate some things. And then I wanted to mention that we had talked about whether or not to include the viral medication, and it feels from a lot of the feedback we've gotten that that might be one other one to eliminate without a lot of conversation.
Follow up on that, I guess, Ms. Hoagland, I was going to reinforce for everyone here today that the AIDS Drug Assistance Program does allow anyone of 550% of FPL to participate in that program. That equates to approximately $86,000 a year for a household of one and like 170 some for a household of four. Also, so that for the general public, that does pay the patient copay as well as the premium for the member. For those reasons, coupled with the public health nature of that medication, I'm glad you mentioned it, Ms. Hoagland, but that would be a drug I personally would remove from the list. But I know that's a kind of off the subject from what we're doing right here, but I wanted to mention it.
And that's Odefsey, I believe, and it's not really showing up on any of the
Okay, so when it
highest, biggest impact to the whole system, accumulative between payers and the patients paid. And I did do a quick snapshot drill of the total DC claims as well. So here's the DC claims. Again, you're looking at the same kind of drugs as the payer paid: Ozempic, Concentrix, Trulicity, Ozempic, Jardiance, of course.
I recognize we may not have all staff on this meeting today, but would someone be able to help us look at just, I know visually we're doing it going up and down, but I'm getting a little confused. Could someone help us just cross-link what would be on both lists according to those two things that we've been discussing? The APAC and the DPT?
So that we'd have to show the dashboard. I'm not sure if the dashboard is equipped to show those next to each other. Heather, are you able to?
And maybe we don't have to have it shown, but even if someone was able, I know this is all real time and an exceptional amount of work to be asking. I was just trying to see if it would be apparent to us essentially what's redundant on the two. so that we could focus on those. I guess that would be my intention.
Let me see if I can move this.
Is that the will of the board though, before Courtney kind of works on that? I was trying to lean into what Dr. Hartung was saying. Dr. Hartung, you have the floor.
Oh, can you, I'm sorry, can you clarify what we're trying to do again? Sorry. We're trying to filter on number of enrollees who received the drug and then and then the total spend.
That's my understanding, and looking for drugs using that criteria that essentially are top of DPT and APAC. Is that a accurate summary of what you were intending with your previous questions?
Yeah. So I guess I was thinking in terms of, before we even think about the source of the data, like, okay, because we can think about the total expenditures in the state and what source is a better capture of that. And to me, the carrier data or the data call is, because it is net spending. But the utilization, like how many patients are taking the drug, it might be better reflected in the APAC data because it's more comprehensive. Granted, it does have Medicaid and Medicare. It does have Medicaid, which again is like a separate issue.
And that, I mean, that goes back to kind of what is our guiding light. I think one of the things I heard, or I thought I heard from my colleagues today, was that we really did want to lean into like number of Oregonians impacted, right? And so to your point, Dr. Hartung, that would be the APAC number, but possibly the DPT net. Is that?
Yeah. And maybe we could just do it by hand. We only have 20 some drugs
Yeah.
here. So maybe we could just do it by hand too, in terms of like, if we're going to do that, rank it by total net spend according to the data call, and then just glancing at the APAC number of enrollees. And if there's some threshold number that we say, it's not, the number of Oregonians who are taking this drug is below X number, we're not going to include it in this year's affordability review.
Okay, so Dan, just to clarify what I just heard, you want to take what under the data call, which is net of rebate, or do you want to take the APAC payer paid, which includes Medicaid and Medicare? Right now it's filtered just on commercial. I don't have Medicaid and Medicare in here.
Oh, okay, cool.
So
yeah,
we can
no.
get it from this perspective, APAC, but realize that, and again, it's a system overall because it has all the additional carriers outside of the 11 that reported from the data call. So you could do this number here. I apologize. So you're looking at then these, I think it's the 12 that shows up right here. Is that what you're kind of saying?
Yeah, so using the data call as the variable to prioritize, to be the prioritization, and then also considering the APAC number of enrollees. As we go down this list, and we can just say, how many do we want to, Chair Bailey, you mentioned having a number in your head, and then just kind of saying yay or nay until we get to that number.
All right, and then the APAC number of enrollees. So it's filtered on that. Let me pull over my screenshot.
Well, I don't even think we need to we don't need to do any sort of fancy screenshots of things like that, because can't we just look at the numbers?
You are, but if you're trying to pull off, so here you're still looking at one drug, so Ozempic, so that would be one drug in itself. you should at least look at getting over 9 drugs to select, because you have to select 9 drugs for the statutory.
Courtney, I'm sorry to speak out of turn, but I think he's just saying, like, you look at the first list you had and then say, I'm gonna pick a random number, guys. This isn't the number, but like say 250 is our number. And if it's less than 250 people, we're not counting that one. You know, so is that right, Dan?
Yeah, exactly.
Okay. So if you look at the enrollees, then
And I want to acknowledge, we do see Mr. Judge and Ms. Hoagland's hands raised. I just wanted to let Courtney get through a little bit of this before we throw more at her. Is that acceptable to the two of you?
yeah, I just want to make sure that I'm trying to capture.
Yeah, I just didn't want to confuse it.
I mean, yeah, the range can come up with whatever the board feels is most relevant, but I'm good with where we're at now. So if Lori or Robert want to make their
Well,
statement.
yeah, actually, my comment was made by Chris. You know, I think look at system costs, then we'll go to impacted individuals, impacted people, and then just make a cutoff. And we just have to figure out what that cutoff is. And that would work for me.
And Ms.
I second that too. I think, you know, cutting off people at an agreed upon number of enrollees and then looking at what we have from there.
So this is kind of.
And for the record, then, I just want to reinforce, it sounds like the will of the board for this 2025 affordability cost reviews is essentially payer expense and total number of patients impacted. That's what I'm hearing is going to be what guides us throughout the rest of the year. Is that an accurate assessment? Mr. Judge and Mr. Lehman, your hands are raised, and Mr. Murray.
Yes, Chair Bailey, that makes sense to me.
Mr. Lehman?
Yeah, I was just gonna say, I agree with that, but the way it's filtered right now isn't that way. Courtney, you could clear the filters and just go by DC payer paid, I think.
And we're looking at commercial. That would be the other piece.
Yeah, so if you want to look at the whole system, we're just commercial. So that's what it's filtered on right now, is this commercial.
And then if I am hearing what I feel like I said is you don't need to put a filter on the number of enrollees. We would just come up with what the number was and say, yes, it's in, or use that logic to filter them in or out.
Agreed.
So with the APAC, do you want it filtered on just commercial and remove Medicaid, Medicare as well?
Why would we remove Medicaid, just out of curiosity? Or there were comments about including Medicare. Somebody needs to teach me about that, please.
I had a related comment. Let's just talk this through here before we start filtering stuff. From a patient, yeah. So I think, you know, that was the caveat. It's like we have some filters on the paid, net paid, but they weren't also on the number of enrollees. And so there's a little bit of a discrepancy in terms of kind of who we're counting in what bucket. But I think from the, you know, I don't know. I think probably arguments could be made both ways in terms of like including or not including Medicaid. But maybe for simplicity, we include everyone in the net paid. Well, I guess the Medicaid is not even in the data call.
That's correct.
Okay, but Medicare is.
No, Medicare and Medicaid are not in the data call.
Okay, so it's just commercial. So I guess the question is, should we only consider the number of enrollees in APAC if they're in just the commercial side as well, or we'll just say the entire, Oregon state?
Mr. Judge?
Yeah, so I struggle most with including Medicaid for two reasons. One, the member impact, the patient impact is pretty de minimis because they have no copay. And then if you look at the total cost, I don't know that this has Medicaid drug rebate program money factored into it. And that's really where Medicaid covers a lot of its costs through what manufacturers pay through CMS and to states. So I don't think we did a clear picture by including Medicaid in this. Medicare is a little more troubling, and well, it's the next more troubling item. Not so much that the data wouldn't be relevant, but I get when we start mucking around with potentially doing affordability reviews, I just want to make sure that we're staying in our lane and don't bump up against anything that CMS has in terms of formularies that get filed and approved by CMS, which is always a little problematic because they have requirements around how many options you have to put in a therapeutic category. So that just gets a little messy for me. Commercial is clean.
Mr. Murray?
My initial recommendation of total paid to the, or total cost to the plan and total out of pocket for the patient would argue against including Medicaid claims in that filter, I guess, because they're a zero copay most all of the time. They are zero copay. So I guess I'm leaning towards the number of claimants, but I'm questioning whether it's APAC, total payer paid, or data carrier. And then the same question with the DC number of enrollees versus APAC number of enrollees. Well, I'm in favor of adding in Medicaid because I want to make that a topic of discussion in future months coming forward. And things that other states are doing in regards to Medicaid. So that's my preference.
So if I'm hearing us right, doing a listen check, right now we've been filtering on commercial. We've been prioritizing payer pay, patient pay. We're looking at DPT, but would there then be a way after we decide on DPT that we crosswalk the APAC volume, knowing that that volume doesn't impact what the price was, but it helps us have a snapshot of how many Oregonians what we're looking at could impact, keeping in mind, while I appreciate Mr. Joseph's comments about Medicaid and Medicare, and I'm in agreement that but I guess I just want to reinforce, we are not doing anything other than shining a light on what impacts drug costs, right? We're not getting into any Medicaid drug rebate questions or things like that. We are just trying to maybe look at how many Oregonians would benefit from reviewing the information we provide related to what drives costs. Dr. Hart.
Yeah, I think that's fair what you said. And I'm looking at some examples where there's great discrepancy between DC number of enrollees and APAC number of enrollees, and that which may reflect this like Medicaid. For like Vraylar, for example, 4,387, APAC 997 in the data call. And so that's a lot of Medicaid in there. And so, if we had like a threshold of 1,000 patients or whatever, that would obviously fall into the 1,000 if we're using the carrier one, but not if we were using the APAC. But you could argue that APAC it's just heavily enriched with Medicaid patients, and we don't need to worry about affordability. That's like an edge case that where that this kind of distinction might be important. But I generally support your proposed algorithm.
Okay. Thank you. And I was actually just trying to put together what yourself and other board members have been relaying.
Creon's another one. I just see that below where it's again just heavily Medicaid, and reflected in the discrepancy there.
Mhm. And just to clarify, when you say payer paid and patient paid, that's based off of the data call costs that the board wants to look at? Or is it the APAC costs?
Hmm.
Oh, I would think.
Because this is net a rebate. This is, or so this is net and this is gross. So this is the bottom line what is paid, that the payer pays, and then enrollee.
I think you have to use data call.
Data call, okay.
Robert Judge's opinion.
I'm trying. So we did data call. So based off of data call payer paid per drug, we're looking at Ozempic, Cosentrix, Trulicity, Jardiance. But did you want to, there's not a way for me just to filter out on APAC enrollees in this
And
process.
Courtney, I think that's where we were saying we need to come up with a number. And then you could just go down the list and say, okay, it's under 500. So that one is out, but we haven't decided on we haven't talked about what that number would be.
Maybe
But
we
we
just-
understand that you can't filter it.
Yeah.
Maybe we just slowly scroll down and we visually look at these numbers so that we could come to something we might agree to. Is that, is that acceptable, Robert? Your hand.
Doing that visual as we're doing it, and it seemed to be a cutoff was about 1,000.
Okay.
And I can't recall if we were looking at APAC numbers then or DC numbers. But there was a drop off, if I recall. It went from 1,100 or so to 900 and some.
Oh, that's of the filter. Because APAC is including the Medicaid, Medicare. And Robert, I don't know if anybody else is having your speakers really, or your mic's really, really hard to hear.
Oh, interesting. Okay. Guilty.
It's okay. So scrolling down, if it's including, so I guess the next question, do we want to include Medicaid and Medicare APAC numbers? I see.
Only for patient volume, but not price, because that would
Exactly.
include Medicaid drug rebate price.
So if we're looking at APAC enrollees, it includes the whole system. So is there a number that the board wants to remove? So like, look at removing those ones, or
Start with 1,000.
okay. Piece of paper here. So anything above 1,000? All right. We're looking at Ozempic, Concentrix, Trulicity, Jardiance.
While she's doing that, Mr. Murray, I see you have your hand raised. Is there something we can discuss while she's working on those filters?
Well, I just wanted to comment that when we use the 1,000 threshold, I think we should take a quick glance at the therapeutic category and make sure that we're not selecting all of one category or the majority of one category to the exclusion of everything else. But just a thought.
While Courtney's doing that, I do want to do a a time check with my peers. Our meeting is set to end in 9 minutes. Is it possible for my colleagues here to stay on an additional 15 minutes? We may lose interpretation services, but I think I should be asking this right now. If anyone cannot stay on, can you please raise your hand or speak up? Okay, without me hearing that, unless we end early, I would like to extend the meeting till 12:15 a.m. Pacific. And Ralph and team, if that creates any challenges related to the vote or interpreter services, please advise me.
All right, we're at 17 drugs by removing anything below $1,000 or 1,000 enrollees. Oops.
Does Perjeta still need to come up? Yeah.
Sorry. Yep.
And as a reminder, while she's doing this, we still have to have the insulin discussion, this would still combined put us at a very heavy lift with number of drugs. So I think we need to try to filter this beyond where we're at right now, if we can as a team.
All right, so we're at 16 prescription medications. Chris, I see your hand up. Sorry.
Yeah, Courtney, now that you have the 16, could we just filter on number of enrollees and take the bottom one and remove it? I mean, because 1,000 was kind of an arbitrary number, but
So these are the lower numbers of enrollees under APAC. Is that what you wanted under APAC or?
well, yeah, I was just putting that out there as a way to get to the 15, which it sounded like was our goal at the beginning.
So we could do Concentrix and Ajobi or just one?
Well, and while she's doing that, Mr. Murray, I want to acknowledge you had your hand raised, and then Ms. Hoagland.
I'm wondering if we've got this list down to whatever number it is with 1,000 and above. Should we go back to our primary sorting though of impact to the system, the cost, the dollar amounts maybe versus number of enrollees? If we remove Cosentix, wasn't that one of the top ones in cost to the plans?
Yeah, 32 million. Yeah, you're
32.6 thousand.
Yeah. Yeah, so you're right. I believe, Mr. Murray, that
Or we could look at costs.
so yeah, at this point, could our next filter be, now that we've done the patient filter, could our next filter be APAC paid amount and choose some below and look at what that patient number would be? Is that a reasonable way to look at it, Piers?
The APAC paid amount?
No, sorry, the DC paid amount. Mr. Lehman, go ahead. You have the floor.
Yeah, I was just gonna say, is our goal just to get to 15, Chair Bailey? Because we just need to remove one more.
I don't have, there's not a number set in stone. I've just had communication with staff, and I want to be mindful that we also have the insulins, which right now, the way we left it is a pretty broad lift. So
yeah, so I guess I would be fine with just removing the lowest DC payer paid one that is remaining on the list and saying, okay, we got to 15, which is great. I mean, I feel a lot better about 15 than I did about the 20 some that we had before.
And it's not a number in stone, for the record. That was just something when I worked, but I hear what you're saying on that, and that could help get us there. I think Ms. Hoagland, your hand was next.
So, thinking now we should look at therapeutic groups, because if we take the last one, which is Trelegy and is the only inhaler on the list, I think maybe we should take the lowest hanging fruit for the anti-diabetic, for instance, or migraine, one of them that has multiple other choices.
I would hesitate on the anti-diabetic because of the dollar amount, but possibly the migraine. Mr. Judge?
Yeah, I just want to be clear on kind of the organizing principle first. I thought we were going to go on DC cost first and then do members second. But it looks like we've gone members first and now we're doing cost. Or did I just misunderstand?
So we're looking at the payer paid under the data call because it's based off of net, and then the APAC overall system.
Okay.
So and honestly, I think that the discussion is fine at 16. I think that the breakdown and not just selecting another drug just to get to a stationary number of like 15. I think 16 is completely reasonable. So if you as a board are okay with these ones, we can transition over to the insulin conversation, because you still have to vote before we log off on this.
Yeah, so then the other, thank you for that, Courtney. So I'm cool with kind of being 16, although I thought Chris's comment of just chopping from the bottom made sense if we needed to go there. But I do think Laurie's question about whether we're heavy in some areas and whether we should introduce a therapeutic class, that might be polishing the apple. But if our attempt is to be as inclusive of therapeutic categories as possible, then that may be something to entertain. I don't have a strong perspective on that.
Well, then, thank you. Mr. Murray, before we have the insulin discussion, your hand was raised. Oh, you're on mute. So if you're conveying.
Thank you. Sorry about that. Yeah, I think the things that I was going to say have been said. So I'll lower my hand. Thank you.
Mr. Lehman?
Yeah, Chair Bailey, I was wondering if we could vote on this now instead of going to the insulin and then having like 2 votes or something like this. So I don't have a motion to read, but I would move that we move forward with the 16 drugs on the list that we have all agreed to here, if that's possible.
Ms. Hoagland, your hand is raised. Is that a second?
Second that.
Okay. Before we vote, we may need some language on the screen, but before we vote, for the record, I just want to outline what our methodology was to the way I understand it so that we have it on the record. So the methodology I believe we used was the DC cost filtered from highest to lowest, number of members, highest to lowest. We were focused on commercial. And the number of members, although the pricing wasn't linked or the cost wasn't linked from APAC, the volume of members was. Is that everyone's understanding of what our methodology was? Because I want to be very clear for the record.
Well, what we have selected now is all on data, isn't it? It's not just commercial. That's what I'm looking at on the screen, I believe. Is that correct?
Correct. Yeah. So the APAC number was all.
Was all. Okay. Then I'll amend it. I just wanted to be very clear for meeting minutes moving forward. What we did. Mr. Lehman.
Do we have to mention in there that we filtered out the number of the less than 1,000 enrollees?
Very good point. We also did that.
Yeah.
So maybe I'll try one more time because I know we're short on time. We used DC cost, number of members, and we filtered sample size under 1,000. And that is how we came to our total universe for what we are voting on right now. Okay.
That's correct.
So I don't know if we have to call these drug by drug for vote, or if we could rather, we have a motion, we have a second. If we could advance the vote, just referencing what we all see on the screen, or do I need to quickly write down all of them and say them drug by drug?
No, it can be a vote based on the decision of the drug via the.
Okay, so then I guess I would like to ask Melissa to call roll because we are, I guess to be more formal, do we have a motion to move forward with the subset list as it appears before the board at 12:01 a.m. on June 18th to be the subset list of drugs that will be under review for the 2025 affordability reviews. Do we have a motion to approve the list as we see it? Looks like we have a motion, Mr. Lehman.
Yeah, I didn't write down everything you said, Chair Bailey, but yes, I motion to approve the list as it appears on the screen currently.
Thank you. Mr. Judge, is this a second or a question?
Well, actually, we have a motion on the floor already for this with Lori Hoagland seconding. So unless we dismiss that motion, we can't have another different second in place. So we need to act on the motion that's in play already, which is already, you know, what we talked about, the 16 that Chris mentioned. So
Thank you.
he didn't mention selection criteria in his motion, but as long as we have record of it, we're good to go.
Thank you. So we have a clarification. We have a motion and a second. Melissa, if you could please call roll.
Dan Hartung,
Aye.
Lori Hoagland,
Aye.
Robert Judge, Chris Lehman,
Aye.
John Murray,
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you for facilitating that, Melissa. Courtney, if you could have Heather and yourself go back to the insulin dashboard. We do need to together decide as a board what our methodology will be for the insulin.
Yeah, Heather, if you could show that, I'm taking some notes real quick to get the current list.
And as you're doing that, Heather, I'll also remind before our meeting commences, after the insulin, we do need a vote to approve the meeting minutes from the previous meeting. So is it the will of the board to keep the insulin the way we have it right now, or do board members have other opinions related to how we want to see insulin presented to the board as we do our affordability reviews for 2025? Dr. Hartung.
You know, I'm of the opinion that we include all the glargines in the affordability review, just emphasizing what John Murray said, that a lot of it's just going to be the same, you know, overview of the therapeutic alternatives. These are all, you know, some are interchangeable, some are not, but they're biosimilar and very similar. And so there's going to be a lot of the same. So I don't think it's going to be a huge lift. And, you know, the big distinction is going to be the pricing issues between the two. The one filter I think we could do is like on the number of enrollees. You know, some of these are like pretty low. So we want to, again, select a number, I don't know, 1,000 or 100, and then just take those off. But I'd like to see everything in terms of, and most of the stuff is already here embedded in these various things. It just needs to be presented in a more coherent way in the report.
Is it staff understanding that what board members believe related to time allotment for glargine, would it be necessary to have a full meeting on it, or could we, is there a lens to do this that it wouldn't take an entire meeting? And or do we want to be in alignment with what we did with the previous vote and cap the number of enrollees at 1,000? Or would that not be in alignment with the will of the board? Mr. Murray?
I would like to see us follow similar guidance that we did to the other drugs. I'm okay with dropping off the bottom two based on not only DC payer paid per drug, but also APAC number of enrollees. That would get it down a couple anyway, but still give what I'm hoping for as a comparison across glargine in the marketplace. And I guess for the sake of time and for discussion purposes, I'm going to make a motion that we drop off those bottom two Resvoglar, and Basaglar based on DC payer paid per drug and APAC numbers, and include the rest for affordability review.
Thank you, Mr. Murray. Ms. Hoagland, you have the floor.
I will second that.
Thank you. So I'll go back to the question for staff. At this number, would this take an entire meeting for review?
It's my hope to not have it. It may be best to review insulin products later on in the year, not as the first one, but we can probably make that happen, which actually does bring me to a question of what kind of bucket the board would like to review first, but maybe I'll just set it up and for best option to start reviews in July.
Good.
Since we have such a different structure of drugs than what I'd put suggested buckets in, but we can take care of this. I think that we can do this. It just has to be later on in the year.
Okay, Mr. Judge?
Yeah, there's a motion on the floor and it sounds like we're still debating whether we can even do this. Do we need to resolve that first before we entertain the motion?
I believe what I heard from Courtney is that it may not take an entire meeting to review these. So I would assume that the original motion from Mr. Murray would stand because staff confirmed that we could possibly do this in less time than one full meeting for Glargine. That's what I heard, unless someone heard differently. Mr. Murray?
And I would say that I think the recommendation of holding, because this is kind of a unique situation where we have a number of drugs, therapeutics information is going to be the same throughout, that we do hold it to the end of the year. I am hoping that we get better at affordability reviews as we work through the process on a one-by-one basis. If we get toward the end of the year and what we've selected for insulin is unattainable, then maybe we can revisit the motion and the selection and modify it as needed. But I think that let's proceed and start with the other medications, other drugs that we've talked about in the previous discussion.
Thank you for your comments on that. So I guess with that said, it appears as though we have a motion to advance the insulin products that are before us today. And we received that motion from Mr. Murray. Do we have a second on that motion?
I seconded that, I think.
Oh, my apologies. We have a motion and a second. So Melissa, can you please call roll related to voting on the insulin products that are before us today to advance for 2025 affordability reviews?
Dan Hartung,
Aye.
Lori Hoagland,
Aye.
Robert Judge,
Yes.
Chris Lehman,
Aye.
John Murray,
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Melissa, thank you for that. I do now want to move back to discussing the draft minutes from the May 2025 meeting. I would like to ask if there's any suggested modifications to the meeting minutes from that meeting. Looks like with there being no amendments to those meeting minutes, Melissa, can you please call roll related to the approval of the May 21st, 2025 meeting minutes?
Dan Hartung,
Yeah, aye.
Lori Hoagland,
Aye.
Robert Judge, Chris Lehman,
Just as a point of clarification, John, I made a motion earlier to approve the minutes and we got a second for it. You weren't here, so we had to wait, but we have already had a motion to approve the minutes. So I vote aye. I'm fine with that.
Thank you. Thank you for that.
Is
And
that-
Dan Hartung was the second.
And I do want to go back to Mr. Judge because I think his audio was cutting out and he may want to amend his answer based on the fact that he wasn't at the previous meeting. Mr. Judge. We are struggling to hear you. We cannot hear you all. Can you give us a visual representation of if you want to approve the minutes from the previous meeting with an up or down, thumbs up or down, based on your absence?
Mr. Judge,
Miss-
he abstained originally.
He
Would you like
did.
to abstain?
Doing the verbal confirmation
Okay.
for Mr. Judge that he is abstaining from voting on the minutes.
Okay, thank you. We had John Murray is next. And Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. I do now want to reference that the next board meeting is July 16th, 2025 at 9 a.m. There being no further business before the board, all in favor of adjourning the board meeting, please say or visually depict yes.
Yes.
Any opposed, please say nay. All right, meeting is adjourned.